ஸ்ரீ மணக்குள விநாயகர் கல்வி கூறுவோம். மனதுக்குள் நன்றி சொல்லினாலும் மகிழ்வோம். எங்கள் துணை வேண்டும், உந்தன் அருள் வேண்டும், என்றும் ஜெயமாக உந்தன் வரம் வேண்டும். விநாயகர் ஸ்ரீ மணக்குள விநாயகர்.
Thank you. Please be seated. I now request the dignitaries on stage to kindly proceed with the lighting of lamp symbolizing knowledge, purity and illumination of wisdom.
Thank you, dignitaries. I invite Dr. M. Vimal sir, Professor of Pathology and an esteemed member of Medical Education Unit, known for his dedicated commitment to medical education, to deliver the welcome address. Over to you, sir.
Good morning and warm greetings to one and all. It's with a great sense of joy and with a deep pride, I welcome you all to MedAIR 2025, the international conference integrating artificial intelligence, innovation and research in medical education, hosted by Sri Manakula Vinayagar Medical College and Hospital, Puducherry. It's really a privilege for us to host you here today. My heartfelt gratitude goes to one person whose vision makes all this possible, our beloved Vice Chancellor of Takshashila University and Honorable Chairman and Managing Director of Sri Manakula Vinayagar Educational Trust, Honorable Sri M. Dhanashekaran sir. His dream has always been to raise our institution to international standards, not only in infrastructure, but also in academic leadership as well as in the global visibility. And today MedAIR stands as a example of his vision. We are thankful to sir for his constant guidance and support in all our endeavors. My heartfelt warm welcome to our respected Director R.N. Kagni sir, a leader who blends a rare academic vision, institutional discipline and constant support in all our endeavors. His constant support and guidance has been made this MedAIR into a landmark event in our institution. Welcome, sir. My warm welcome to our Dean Academic, Dr. K. Karthikeyan, sir, a leader with academic excellence and innovation who has been a guiding light for all our endeavors in MEU. Welcome, sir. A heartfelt welcome to our Dean Research, Dr. P. Sanjay, sir, who nurtures a strong research culture in the institution with innovation and a critical reasoning and evidence-based learning. Welcome, sir. A heartfelt welcome to our medical superintendent, Prakash sir, M. Prakash sir, and Dr. Girija ma'am for their constant support, who always believe that patient care and medical education should go hand by hand. A special welcome to our Deputy Dean Academic UG and MU Coordinator, Dr. K. Soundarya, who is the heart and soul of our MEU, who nurtures it with unwavering care as if one would a child. Her tireless dedication and constant support have been the invisible forces which have been the milestones which our MU has been achieved. Welcome, ma'am. A cheerful welcome to Dr. R. Uday Shankar, our organizing secretary, whose tireless dedication and meticulous coordination have brought this grand puzzle together. And the midnight oil which he has burnt has now seen the glow of this MedAIR. And thank you for your shared dedication which make MedAIR not just possible but an exceptional one. Welcome you, sir. It's my honor to welcome our distinguished resource persons who are here to guide and inspire us through their vast experience and wisdom. Professor Janet Grant, her Honorable Professor at University College London Medical School and Director of SENMEDIC, a global pioneer in medical education who has led international policy initiatives, shaped WFME global standards and advanced context-based curriculum design worldwide. Welcome, ma'am. A warm welcome to Dr. Avinash Supesar, ex-Director of Medical Education and Major Hospitals and former Dean of KEM and Sion Hospitals, Mumbai, BC Roy Awardee and Senior NMC Advisor, a national leader in surgical educator and a key architect of India's CBME framework. We are honored to welcome you, sir. A heartfelt welcome to our Geetanjali ma'am, a former Director of AIMS Bhubaneswar and Vice Chancellor of Medical Sciences at Geetham University, a distinguished pharmacologist, academic leader, a founder of JIPMER's WHO Collaborating Center on Essential Medicines, who pioneered the growth of AIMS Bhubaneswar, an inspirational leader for driving force in faculty development and clinical governance. Warm welcome to you, ma'am. A warm welcome to Dr. Himanshu Pandya, sir, Dean Pramukh Swami Medical College, a pioneer in curriculum reform and digital innovation shaping faculty development at the national level. Welcome you, sir. Dr. Kadambari D, ma'am, welcome you, ma'am. Professor of Surgery, JIPMER, who blends surgical excellence with a strong focus on educational research, mentorship, and competency-based training. A warm welcome to Professor Izzat Jayaprakash Rajan, sir, Professor and Head of Medical Education Department, JIPMER, a national leader in faculty development and e-learning whose training programs have empowered educators across India. A warm welcome to our resource persons for the workshop also. Welcome Anand sir, Professor from Manipal University, Malaysia, an international mentor in interprofessional education who brings global insight into collaborative learning. Welcome, sir. A warm welcome to our Professor Dr. Amol Dongre, sir, Professor of Community Medicine, a pioneer in qualitative research, a mentor to generations of educators and researchers. We also would like to welcome Dr. N. Suresh from AIMS Madurai, an innovator in anatomy education known for integrating ICT tools across disciplines. A welcome to Dr. Frank Umarnath from AVMC, Dr. Arvind Bhaskar from SRM Chennai, Dr. Rajkumar Ilancheran, and Dr. Gunasilan and Dr. Logamurthy from SMVMCH, who are our resource faculties for the workshop. A warm welcome to all our delegates from institutions across the India. And your presence is what makes MedAIR more meaningful. Your presence brings energy, purpose, and heart to this gathering. MedAIR is the result of countless hours of tireless efforts by our team members, And today this MedAIR stands as a testament to what we can achieve when we come together with passion and purpose. To all our delegates, welcome you on behalf of our entire MedAIR team. Welcome you all.
Thank you for that warm welcome, sir. I now invite Dr. K. Soundarya ma'am, our dynamic Medical Education Unit Coordinator and Deputy Dean Academic UG, whose passion for teaching innovations has driven many initiatives to present the journey of Medical Education Unit at SMVMCH. Over to you, ma'am.
Good morning, everyone. So, welcome you all for this MedAIR International Conference. While we started planning for this before 6 months, to be very frank, it was a nightmare for me. Now I really test myself whether it is truly happening. So, we have come to this point, and it is really happening today. So, I should thank everyone for that. I should not take Uday's message. He will deliver the vote of thanks. So, I am here to talk about the journey of MEU, how it happened since 2006, the inception of our institution. So, I'm really, I didn't prepare anything. I'm just going to talk on it. And I'm really privileged to stand here to talk about the building that has come up to this particular level. So, to start with, okay. To start with our academic architects of MEU. So we have our former director, Dr. Rajagovindan sir. So when the guidelines came that medical education unit has to be implemented at every institute of our college. So it was Dr. Rajagovindan sir first took the initiative to implement it at our institute, and followed by Dr. Karthikeyan sir took over as the MEU coordinator, and followed by sir, it was handed over to Dr. Kalaiselvan sir, with a strong support from our Dr. Amal Dongre sir. So I have special slides to talk on them, but to summarize, these were our major people who laid the foundation for medical education unit, on which I am standing now and presenting it to you. These are my cruising crew. Though it is a ship, they all are ready to get down into the ocean and push it right to the shore. They will be with us at any time and making the FDPs, whatever we plan, it's successful. And I have missed Dr. J.K. Pumalar ma'am and Rajalakshmi in this. Thank you all, dear friends, for bringing MEU to this particular thing. So, a special mention to Dr. Uday Shankar. For the past 6 months, he was not only tolerating the stress of organizing the conference, also my stress. Thank you so much, Dr. Uday Shankar. You always stand special. And to share a few words on our visionary beacon, Dr. Karthikeyan sir. So when the MEU inception began, it was the institute will have highly experienced faculty who have the principles of medical education imbibed within them. Those were the period where the principles of medical education were not made explicit. So, conducting workshops for the legends who are already well versed in medical education is such a challenging part. Sir, you stand very different in organizing the workshops during that period. Thank you, sir. Thank you so much. And moving on to the next one. So, next the MEU was handed over to Dr. Kalaiselvan sir, a very cool person who just deals everything so lightly. I should learn a lot from him even now. And sir was very successful in conducting so many FDPs, and sir was a MEU coordinator in this institute for more than a decade actually. And I should not forget to mention about a man with a small smile, few words, but his actions speak louder. Dr. Amul sir. Sir was a major pioneer during that period who strengthened all the activities of medical education. Sir was the one who instilled professionalism in each and every FDP which was organized by the medical education unit that period. Thank you, sir. Thank you so much for your inputs. And these were the successful programs which are organized by MEU for the past 15 years. And I should make a special mention, even before the implementation of competency-based medical education by our NMC, with the inputs from Dr. Amul Dangre sir, Dr. Sheetal sir from Nepal was invited for a workshop on problem-based learning and competency-based medical education. And I should say, our director, Dr. Kagne sir, and myself were in the same group, doing a group activity on the definition of competency during that workshop. I still remember it, sir, and it was facilitated by Dr. Amul Dangre sir. And even before the foundation course was made mandatory, announced by the regulatory body, we used to conduct the orientation program for our first year students, and even we planned the white coat ceremony well in advance. So these were the people who are not currently in our institute, but their role stands very strong. They played a major role in building up the MEU. A special regards to our Dr. Jayashree ma'am, who is the current Dean of Takshashila University. And late Dr. Vinod sir, I will not say that sir is not with us today, but he is always alive in our memories. Provided sir had been here today, this conference would have been organized definitely by Vinod sir. We miss you, sir. And a special thanks to Dr. Murugan, Dr. Suguna, Dr. Vinayagar Murthy sir, Dr. Suresh, Dr. Asmatullah, and Dr. G. Ramya, who all were part of MEU in the past few years, and currently now they are not, though they are not present in our institute, but their contributions always stand sound. Yes, behind everything, we have our current director, Dr. Kagni sir. I didn't mention anywhere about sir in the previous slides, a silent man who doesn't speak much about himself, but he remains invisible everywhere, looking at everything, lending helping hands at any time. When I took over MEU, I was a very junior faculty. I was struggling to organize the FDPs. Sir used to stand by my side. You imagine a leader of the institute standing near a very junior faculty organizing the FDPs, starting from the banner arrangements to the snacks to organizing the program. Sir used to stand by my side, encourage me, motivate me. Sir will always say, you can do it, don't break down. Sir, thank you, sir. You have made me to stand at this level, always indebted to you. What role he doesn't play, I don't know. I don't have words to talk about, sir. And have you all heard a head of the institution sitting in your FDP at the last row, enjoying the ice-breaking sessions, laughing, enjoying it, coming at the end, ensure that everything went well smoothly, whether any difficulties faced by the organizers, by the participants, sir, ensures everything happens smooth. Sir, no more words to talk. Thank you, sir. Thank you so much for your contribution. And we are proud to say that at least minimum we organized 12 FDPs of FDPs per year by our medical education unit. We ensure that the principals reach even the senior residents and the junior residents at our institute. Thank you all our staff to cooperating with us in participating in these FDPs. We may organize 100 FDPs, but without your participation, it doesn't have a meaning. Thank you so much. And so these were the various FDPs we used to conduct by our MEU in the past few years. And whenever I go to attend a workshop related to medical education unit, people will give a checklist whether this has been implemented in CBME. So I will be the first person to say, yes, all the components of CBME has been implemented at our institute. They all used to get surprised. How is it possible? I will say I have a visionary leader with me who ensures that everything gets implemented at our institute with a small smile in his face. So thank you, sir, for being successful implementation. And with sir's vision, we have efficient members in our team. Through our various subcommittees, we ensure that each and every component of CBME gets implemented at our institute. And thanks to Dr. Amul sir again for laying the foundation for the student support system. We stand definitely unique in organizing the student support system for our students. It started even since the year 2012. I still remember Amul sir invited all of us and explained to us the definition of a mentor. Sir, we are standing here now successfully running the student support system for the past 6 to 8 years. Thank you, sir, for your support. And we also have some 3 copyrights through MU, proud to say on that. We have more than 58 publications in well-indexed journals, and we have even some good book chapters published. And these are our future plans. Being converted to autonomous states, we are in the process of blending the national education policy, and why don't we think of creating a credit-based framework for our UG curriculum. And we are planning for more collaborations with the international institutions. And what more to talk, I don't know. So I have expressed everything what I had in my head. I don't have anything in my paper. If I missed anything, it is purely by chance. And thank you all so much for standing with me at any time. I don't have an efficient, I will not say I have an efficient team behind me. No, an efficient team has projected me in front of you to stand forward. And I always tell Uday Shankar, before I step down from MU, I should have conducted a conference, and I am successful. Thank you so much.
Thank you, ma'am, for showcasing our vibrant journey. Under a visionary's leadership, our institution has grown into a center of academic excellence, nurturing innovations, while upholding the values of compassion and service in medical education. We now request our Honorable Director, Dr. R.N. Kagni, sir, to deliver the presidential address and opening remarks. Please, sir.
Good morning. Good morning, one and all present here. Dignitaries on the dais, off the dais. It gives me a great pleasure to be here among you all the great visionaries of medical education sitting right here, the great teachers, all the faculty members, dear students. Medical education conference was thought just in the month of March. And it was very difficult to plan it because everybody was tense how it will happen. So we are thinking whether we'll have first national conference and then we'll go next year for the international conference. Then we had a discussion in MU unit. We discussed a lot. And then we thought we'll go with international conference only directly. Because we know JIPMER conducts international conference of medical education every alternate year. And we came to know this year it is not there. So this is a better and golden opportunity to encash on that. So that next year we'll not do. We'll also go alternate years, like that we thought of. So all the members of MU accepted and then started the journey of planning for the international conference. So their first thing came, what will be the name? So every conference, MedCon and other names were there, so what the name we should give. Then we thought of first theme also, what theme we should have. So keeping in mind this AI coming into the picture, all the transformation happening through the innovations, and medical field not be bared. It has to get involved into that. So whatever changes are going to happen is not going to happen only the engineering field or some other fields. It is medical field also is going to happen. So we thought of that a lot and then had a theme of having integration of artificial intelligence, innovation and research. Then it came in idea that artificial intelligence will be A, innovation will be I, and research will be R. And medical education, we thought of MEDU will be better or only med will be better. And lastly, everybody voted for MedAIR. So this way the name has come. And then the journey started, and then thank to all the MU members and particularly Amul sir for getting international speakers. And we started to launch this year itself and decided the month is going to be July. Time period was less, but thank to all the organizing members, particularly the MU coordinator, organizing secretary, faculty coordinators, and supporting team along with the students. So they have done a wonderful job. Yesterday's workshops, every workshop we planned will have 25 people, not more than that, so that it will be delivered betterly and received also in a better way. But lot of requests were there, so we could not stop on 25. Some workshops went up to 30 number. And yesterday all the workshops were actively participated by all the participants with a great interaction, and hats off to all the speakers or the organizers of the workshop. They have done a great job. I can say that though today the conference is to be there, to be conducted, it is already MedAIR has been successful because of all the efforts of all the members who has taken into for organizing this event. And today's event, I don't want to come between the great speakers and audience because I know everybody is eager to listen to all the stalwarts of the medical education who are enlisted in the list of today's conference. And I am also eager to listen to them. So I once more thank all the organizing team and particularly the participants without whom this day would have not been seen. It was not possible to have workshop without participants and their active interaction. So I thanks a lot everyone again. Thank you all.
Thank you for that insightful speech, sir. Your words truly resonated with us and left a lasting impact. To conclude the inaugural session, I invite our tireless and dedicated organizing secretary, Dr. R. Uday Shankar, sir, to deliver the vote of thanks. Over to you, sir.
Yes. So good morning all. So I'll not take much of time because we are running short of time. But it's customary to give the vote of thanks, but I always feel it's not custom. Being grateful is one of the greatest virtues of mankind. So I should thank all the person who are behind me and before me and above me, all of them I should thank. So it's my honor and privilege to propose this vote of thanks for this remarkable conference about which all of us have spoken a lot, so I'm not going to go into that. But on behalf of the organizing team, I extend our sincere gratitude to our chairman, Sri M. Dhanashekaran sir, his visionary leadership, support, commitment to academic excellence. All this has made this event possible today. So I thank him. Because of busy schedule, he cannot make it today. Otherwise, he would have definitely been present here. So on behalf of our organizing team, Medical Education Unit and the entire institute, I first propose my vote of thanks to our chairman, sir. I also extend a heartfelt gratitude to our director, R.N. Kagne, sir. So I think madam has elaborated what sir's personality is, what his demeanor is. So it is through your consistent backing and thoughtful direction that we could achieve this feat, sir. Thank you so much, sir. Very special thanks to our Dean Academic Karthikeyan, sir. Each and every step of this organization, his vast experience in conducting such events, his inputs, even from deciding the theme of the conference. He said you should have a definite theme. That's why you can see everywhere is green. So that is the theme of this conference. So all the brochures, invitations, banners, everything will be green. So even from the simplest thoughts, all the you will not believe all the organization people were involved in even the smallest of decisions, and their inputs were so commendable. I thank you so much, sir, Karthikeyan sir. A special thanks to our Dean Research Sanjay sir and Medical Superintendent Dr. Prakash sir and our Deputy Medical Superintendent Girija ma'am for their constant guidance and support. And a very, very special and heartful thanks to Professor Dr. Amol Dongre sir from Community Medicine Department. So we have seen what SMVMCH is today in education. I can say he is one of the strongest pillar of SMVMCH. Wherever he is a torch bearer for SMVMCH. So I can say that with proud. His commitment to academic excellence has greatly enriched our discourse and elevated the stature of this gathering really, sir. Thank you so much from the bottom of my heart. And it is because of his efforts we could have such big stalwarts in the house. I will so proudly say that most of us call me and ask whether all the stalwarts are coming online. I'm sure they will be coming online, no? So I put my session morning, so such things were happening. But I told them all are coming offline, sir. Only Professor Janet ma'am, because of the thing, we could not bring her to the place, but otherwise she is joining us online in the afternoon. Otherwise, we are very honored to have all the great stalwarts whose names sir has mentioned. I'm not going to repeat because of the shortage of time. Please pardon me, but I am very, very honored to all these respected people whom I have seen them as teachers. I was growing seeing them, Geetanjali ma'am, Kadambari ma'am, I can see Sivaraman sir here. So all great people, Himanshu sir and Avinash sir, Ravindran sir. So I am standing in front of my teachers. So it's a great honor actually to be in this stage. So thank you so much to all the speakers, and a special thanks to Mr. Anand sir, who has traveled all the way from Malaysia. In person he has come and graced this occasion. Thank you so much, sir. And I also thank all the resource faculties of yesterday's workshop who has tirelessly planned and meticulously executed the workshop. They have owned the workshop. It is not like Madam said it's a stress, but actually I enjoy this the entire process because each of the resource person owned their workshop. So I need not run behind them to get what requirement you want. They are behind me. These are the things I want. These things I want. It was very easy for me, and I always have these people behind me. Even for the smallest petty thing, sir once even said, "Don't think this is the smallest issue. I should not go to director. Whatever it is, you come to my office." He uttered this word. So I could not have asked for more. So it was not me or madam or anyone. It's the combined effort. It's a great team. One cannot pull a chariot. It's everyone who has pulled this chariot, and we have brought it to this stage. So special thanks to the speakers. And coming to the main person, it is with heartfelt admiration that I acknowledge the inspiring leadership of our beloved MU coordinator, Deputy Dean of Academics, UG, Dr. Soundarya ma'am. So if I talk about her, I'll get emotional because we are very close to each other. Her dedication, visionary approach, exceptional organizational acumen have been the pillars behind the remarkable achievement today. So I can keep on talking about her because of want of time, because I am the organizing secretary, I should not waste your time. So we sincerely appreciate your commitment, ma'am, to the medical education unit, to all other things. And I will be ungrateful if I don't mention the names of the organizing committee members because they were the strongest pillars. So I would like to mention few names with your permission. So I sincerely thank Professor Dr. Vimal sir for leading the scientific committee team and all the members of the I'm so sorry if I'm not mentioning the name, I'm just mentioning the lead faculty. So for sincerely conducting this all these scientific events today morning, and all these programs were meticulously arranged and everything was taken care of. So very proud, sir, you organized it very well, and the sessions were fruitful. So my special thanks to all the scientific committee members. Special thanks to Dr. Jayalakshmi ma'am, who has coordinated the workshops beautifully yesterday. And my thanks to Professor Dr. Shanti ma'am and Vel Prashant sir for taking care of the registration process. For their stature, they are standing at the registration counter and taking care of all the reception process. So I sincerely thank Shanti ma'am for her effort. And I thank the logistic committee led by Surya ma'am with strong support from Perarul, Vijay Divagaran sir, and Dr. Harish, the postgraduate from Department of Psychiatry. And I also thank our transport committee members, Praveen sir, Dilip sir, and Arul Silvan sir. So I would like to mention most of their job I have taken because I was comfortable coordinating with the resource persons. So thank you so much, sir. And a special thanks to Dr. Ganesh sir for arranging the catering services, hospitality services. He is a pro in that area. So very, very special thanks to Dr. Ganesh sir for taking care of that. And Muhammad Rafat, Dr. Muhammad Rafat from orthopedics for arranging for the hospitality services. And the MC team, entire MC team from Dr. Deepika ma'am, Dr. Pungamalli, the postgraduates, Dr. Shruti, Sriram. So you'll be hearing them a lot. So thank you so much all. And I will be ungrateful even if I don't mention the student council members. So these students stayed till 11 p.m. in the nights for the last 3-4 days, and they were meticulously arranging things. So I should take this opportunity to thank them and wish them all good for all the student council activities. Thank you so much. And lastly, I'll be very ungrateful if I don't mention the participants. Any conference is a success, not because of the organizing, but because of the participants. So thank you so much for showing interest in our conference and registering in huge numbers and making it a great success. As the director sir said, still we are about to start the conference, which it's already a resounding success, sir. Yes, and our gratitude also extends to our IT team led by Mr. Raja, the electrical team, the photography team coordinated by Mr. Rajiv, and the transport team, Mr. Anand. All of them have arranged everything goes smoothly behind the scenes. And I also acknowledge our junior assistants, Mr. Feroz, Mr. Rajesh, and Ms. Sarojini, and all the attenders and all these clerks of Medical Education Unit, Deputy Dean Academic Office, who have been silently working behind, and their hard work is also appreciated in this stage. Thank you so much. And finally, to each and every one of you, thank you for making this conference a resounding success. Thank you so much.
Thank you, sir, for your gracious words. We'll now break for high tea and request you to reassemble in 15 minutes for the scientific sessions. Thank you.
ஃபியூச்சர் பிளான் போஸ்ட் பண்ணிடலாம். கார்த்திகன் சார் இவர் தானே
அவரையும் சார் இது பண்ணுறேன்
ரெடி பண்ணி வச்சுக்கலாம்.
அப்படியே இன்விடேஷன் அப்போ தான் நான் வந்து ஓப்பன் பண்ணி மறுபடியும் ஸ்டீமிங்கில் தெரியும். இன்விடேஷன் வச்சு தான் நான் கூப்பிடுவாரு.
அவ்வளோதானா?
கீழே சார் 2 இது கீழே வாங்க, 2 இது ஓப்பன் இருக்கு. ஸ்லைஸ் ஒன்று இதுவும் எதுவுமே எதுவுமே
தேவையில்லாம் எல்லாத்தையும் க்ளோஸ் பண்ணுறேன். லாஸ்ட் காலேஜில் எடுத்து விட்டுருவா.
We request everyone to take their seats to proceed with the scientific presentations.
இதை பண்ணிவிடுவோம்ல.
லைட்ஸுங்கெல்லாம் ஒர்க் ஆகுதுல்ல, மாற்றி பார்க்கவா? ஒர்க் ஆகுதுண்ணே, ஒரு ஒர்க் ஆகுதுல்ல, மாற்றி பார்க்கவா? ஐஸ்லேயே தான் அதான் ஸ்லைட் ஷாப் நாங்கள் அங்கேயும் தெரியுங்க. ஸ்லைட் ஷாப் நாங்கள் தெரியுமா? நான் தெரியாது. அவன் சொன்னதானே மாற்றுவான். ஆச்சு நான் அவங்க இது ஒர்க் ஆகும் ஒர்க் ஆகும் பார்த்துக்கலாம். அந்த டைமில் நமக்கு ஒர்க் ஆகுது. ஓகே.
We kindly request everyone to take their seats so that we can start with the scientific sessions.
சார் வேறு ஒன்று ஓப்பன் பண்ணாமல் இருக்குது ரெண்டு.
செல்வம்.
Of enriching scientific sessions at MedAIR 2025. For the first session, it is my pleasure to introduce our moderator, Dr. K. Karthikeyan Sir, Dean Academic, Professor and Head of Dermatology. at SMVMCH, known for his keen eye for academic excellence in sculpting young minds. So we kindly request you to introduce our speaker and moderate the session on use of virtual reality in medical education. Please, sir.
Hello.
Good morning. Good morning. I think it's my privilege and pleasure to introduce one of the doyens in medical education, Dr. Avinash Supe. Sir needs not much introduction. Being a BC Roy awardee and his publications more than 342 papers and 625 presentations, and also honored with Doctor of Science Award. I don't think sir needs much introduction, and I think we will be very enriched by his talk on integrating AI, innovations and research in medical education. Over to you, sir.
Thank you. Can I have my presentation? Sure. The topic which I am going to speak is today on virtual reality in medical education. I would like to thank the team of MedAIR, Dr. Kange sir, Uday, Saundarya, Amol and everyone. Now I'm sure virtual reality is something which is, you're creating an artificial environment experienced through sensory stimuli. And all of us have enjoyed many times games into the Imagica and Disneyland and all. These are nothing but virtual reality games. So there are VR sets which are emerged and immersive games. Many of us have played these games before we really go. And when we talk about education and digital surgery, I think virtual reality has come in practically all parts of education, like designing, post-operative, intraoperative. Now I remember way back in '97 when laparoscopic came, we used to have this laparoscopic training through a small VR, and that time it was called as a very low immersive VR. And then came VR adopters. You know, surgery is amongst the most influential adopters. If you really look at VR, surgery was almost 7.7% all over the world. If you really look out of the healthcare, surgery was one which was taken care by the VR. If you look at publications of VR and surgery, look at the kind of publications which have come. Virtual reality and surgery, they have increased over last few years, and large number of publications, almost about 2,000 around publications every year. Now what is most important in VR is the degree of immersion. How much of immersion we are going to be? Are we going to be a low immersive or high immersive? How much you are getting engaged into the whole thing? So let's begin with a very simple thing about illusions. There are types of illusions, you know. That means ultimately VR gives you an illusion, and it could be a place illusion, it could be plausibility, or it could be an avatar-based embodied illusion. Many of you must have been to, say, Empire State in USA, where you go and they show you that you are descending through Empire State and you are seeing the whole New York. That is called as a place illusion. And it's a feeling of being in a virtual environment. Plausibility is when they give you a scenario, you are working in a casualty, you are working somewhere else, and then you are really trying to treat a patient. That is called as a plausibility evaluation. And third is what is called as an avatar-based embodied illusion. That means you create avatars of different people and then you are working with them. So actually either it's a place, plausibility, or avatar-based illusion with which you really work. The second most important is some of the virtual reality is a non-immersion reality, or otherwise it's a semi-immersive or an immersive. What do you really mean by that? The degree of immersion may change, you know, depending upon non-immersive to immersive. I'll give you a few examples. Non-immersive means you could have something like this, where we used to do a laparoscopic surgery or a touch surgery. We used to use this, and with that we used to make people really work. Semi-immersive is like this. This is like you are changing complete laparoscopic surgery, and you are now trying to put a clip, you are trying to do an ultrasound, and then you are trying to put a hand and palpate. This is something like that, what we call as a semi-immersive kind of an environment, where we would like to really look at the liver and do a laparoscopic surgery, put clips, and these are all today available for our students to really learn. But this is something what we call is like, say somebody wants to learn gastric banding. So he can really learn on this gastric banding, and then he can put a clip. So then, the experience he gets is much more. Students also get a feedback, what he has done well, what he has not done well. So the next thing is something like laparoscopic. The lap mentor came somewhere in about 2000. And it started teaching people how to do laparoscopic surgery. So you can hold the gallbladder, you can pull it, it bleeds also occasionally, and then you started cutting, and this is called as a lap mentor immersive systems. You could do something like this, you can have an distension of the gallbladder, abdomen, you can pass a trocar, and then you can see inside, you can take a cautery and you can start cutting liver. Now these are all illusions, but they are immersive illusions. You would like to really enter and do a procedure, and then you can really do a hepatectomy, which is very well with this. This is one GSL lab, this is Rajmandri. They have really developed this immersive lab. Now look at this lab. You can walk into this lab 360 degrees. You can lift the kind of a heart, you can rotate it, you can touch every valve, and you can really see this. Now the students enjoy this much more. Of course it should be part of your learning, not completely replace your learning. Now VR always has a visual content. It was actively participating and reacting on the visual content. 360 degrees, something like that. But now what has happened, previously there used to be a flat screen. So now we have started getting VR heads. We used to get these headsets. Now this was a kind of a thing which I learned laparoscopic surgery in 1900 and something like 95. And we used to have making people learn. This is the way we used to use to how to progress the intestine, and this was a VR, this was called as a mist VR, it was a flat screen virtual reality. But now we have what is called as a cave, that is called an automatic virtual environment. I think if you really see some of these panoramas, Swiss panorama or world panoramas, where you can walk through and 360 degrees rotates with us. So same thing happens in a OT, when you're working in a OT, it would create, so it creates a haptic, tactile and vestibular kind of a response, which was not there before. So to give you VR visual feedback, you could have so many desktop plays, phone-based or something like that. But now we have started getting tactile and haptic. Look at this virtual reality for vestibular rehabilitation. People who undergo cochlear implantation, they need to be trained for vestibular rehabilitation. This is all done through their VR sets, and this is something which is amazing. Then our hospital has got program called Mind Maze. Now this program is for people who are recovering from a stroke. Now what they do, you sitting like this, and they are playing games. Actually elderly people are playing games. And with playing games, they get a particular kind of exercise, also they give a feedback. So the virtual reality helps them to rehabilitate themselves through various kinds of exercises, mentally as well as physically. This is a haptic kind of a neuro-rehabilitation. VRs are used in operating room, like pre-planning, operative guidance, and post-operative complications. To give you an example, we have to understand the word called mixed reality. Mixed reality is one hand we have virtual reality, other hand you have augmented reality, and the third is a mixed reality. So, real environment on one side and virtual environment on the other side, and we have augmented reality and augmented virtuality. And there is a term called extended reality, where you mix with low immersion or a high immersion. Now once you understand, There's a continuum actually, from no device to the VR, we are going from real environment to the virtual environment. So you can have anything which is mixed. To give you an example, this is a created image of liver if I want to do a hepatectomy. Now I can hold this liver, I can rotate it, I can see where are the vessels coming. So this helps me to operate these patients and do it better. To give you an example, and is it useful? All performance of newly devised systems are comparable to the traditional techniques, and people are now started routinely using this in their operation theaters. In fact, there is something called the HoloLens 2, which is now, again, there are a lot of new things coming up, where you can use large 3D images for learning. Like, look at this liver, again, we have created this for our patient, and now I can hold it and I can really see the anatomy, and I can make a liver of this whole auditorium size, and I can rotate it with the virtual reality. So the kind of ease and training which really comes with this is amazing. We can do 3D printing, you know what is called as a holographic navigation. You can create a bile duct by the side of you while operating with the VR, and something like, and this is intraoperative image guidance. I can do a partial hepatectomy, keep it by the side of the patient while I'm operating. I use a VR head and I can really know and see what kind of a resection I'm doing. Now see, I can pinch it and I can keep it wherever I want, and this is the way I can make my operations more precise and doing. And this is all being done. It's not something which I'm talking from heart. We have tried this all and we have been doing many of these. Then iSim VR, you know, I bought for the mobile robot simulator. VR perimetries are done with the virtual reality. Many times when you do a visual perimetry, there are some lacunae. So virtual perimetries are done better. VR operating room planners. You can really create an operating planner so that this is all like CRM, crisis resource management, teamwork, all these are now played with the help of VR. Post-operative reflections, VR can advance your reflection by helping healthcare professionals to relieve situation they have encountered. You can have a debriefing, you can make people learn in that way better. So if you really look, put it into a paradigm, you have can we go back? Sure. Anyway, can we just go back? Just help me. I think it is not coming there. Sure. So if you go to this paradigm, you have a high fidelity versus low fidelity. I'm sure all these medical educationists understand what is fidelity. Accessible versus costly. If you really see, cadavers are high fidelity, costly, not very easily available today. AR, VR are costly, but they are low fidelity. Physical models are high fidelity, accessible, but sometimes there's an ethical issue. And desktop models which are low fidelity and accessible. So we have to really understand which one which you want to use based on what is available to you. Now, what are the educational examples? We can use it for teaching medical anatomy. Many of the colleges today have anatomage. Familiarization with surgical workflows, developing technical skills, managing crisis scenarios, experiencing rare procedures, realistic decision making in a virtual hospital, and definitely having situational and spatial awareness. Now this is something which is very important when people are working in teams. I think yesterday in the gamification, the Raj was talking about this situational awareness. Now this is exactly is very well learned through virtual reality and team training. Now look at this kind of an anatomage. These are there in many labs where you can really, instead of cadavers, now it is being partly replaced by this anatomage where students can build on muscles, they can build on anything. I mean, you can bring muscles, you can bring vessels, and you can start working on these kind of anatomage.
The ureter is closest to the pink zone. The rectum is closest to the red zone. So our green zone in the midline is the one with the greatest safety zone with both the ureter and rectum at safe distances.
Well done. In what direction would you place the suture? Speak the color of the correct arrow.
When we're placing sutures, our area of maximal control is the entry point. So we're going to put our entry point from lateral to medial, as that's going to be closest to the ureter.
So what is this girl trying to do? She's trying to learn how to prevent ureteric injury while doing the
One of the
colectomy.
3 sutures.
So
Which one is the most
it gives a
helpful?
feedback to her also that you have done well
The one
done.
very close
She's
to the
trying to do it
ureter, and that's
VR,
the
she's
one
trying to
raise
say
the
where to
ureter.
put a stitch. Now this kind of a level of training is much different, and the level of competence they get before they enter the operation theatre. Now see, many of our students, we learned it by operating on patients. So there is always chance of getting mistakes. There is always a history of patient injury. But if you learn it like the higher level, then probably the chances you cause injuries are less. You have to learn on patients, I'm not saying, but you can prepare yourself better before going on that. And there are enough amount of publications today which say that augmented reality in surgical training, there are systematic reviews, there are so many publications in transplantation which would help you to say that this has proved to be effective. And if you see use of 3D, mixed reality, augmented reality, whether it has helped into this, there are enough publications which would say that this has been of a great help.
Meanwhile,
Like another thing which people do is the 3D printing. Now what do they in 3D printing?
On the left,
This was I saw in Korea.
on the right,
There was a patient being operated for thymectomy,
tumors are removed.
and they created complete 3D replica of the patient where the students were observing their boss and they were operating and they're doing exactly the same procedure that they were doing for that thymectomy. Now, I think this is a different level of training. You can't really replicate it everywhere. Now, AI has come. AI and machine learning will analyze these investigations and it will predict difficulty. It will guide your port placements today, layering of tissues and dissection, steps of surgery. Like this is a mixed reality. You know, this is where gynecology, many times, today women are very ethically you can't really ask somebody to do, students to do it. So look at this.
The group is going to be understanding the same reality. So
Can
now
you
the
increase the
instructor
voice?
can really focus on how to manage a complication. Nothing ever has provided that level of information. It's not a textbook, it's not a video, it's not a PowerPoint presentation that's going to give you that kind of understanding. CA Healthcare selected shoulder dystocia as the first scenario on Lucina AR because it's a rare complication of delivery, but it's one that's difficult to manage. You have a number of options, you need to think fast. Seeing the anatomy, seeing the progression of the baby in the birthing canal, and seeing where the shoulder gets stuck is going to be very helpful to understand how to fix it. Seeing them in front of your very eyes as a student is like a revelation, right? This is the future of healthcare education. Really beyond the spectacular of that experience, there's an educational purpose that we're fulfilling, and that.
So this is where you can teach your students about complications of delivery and reduce the risk of getting complications. What are the limitations of VR? We need more data to prove its clinical utility and improved patient outcomes. It improves the level of training, but does it improve the patient outcomes? We really don't know. We still have to work on this. Cost is a major issue. Efficiency and effectiveness of VR training simulators. We need to create people who know all this. Cyber sickness. This is another thing which many students have said that we are all the time working with IT. I think this is something which all we have to get through this. This is a future direction of HoloLens based surgery. What we put on HoloLens and we do HoloLens based surgery. And I can be in the remote. Now recently I think people conducted TEVI based surgery. That you are in Switzerland, you are conducting a surgery in USA or in Singapore. This is called as an HoloLens based surgery. Right? To be very frank, I use this technique not for surgery but for teaching in remote countries like say Nepal and Bhutan where there is a good internet. And I realized that as an experiment we did it and it was very, very useful that you could really train surgeons about what they are really doing. You can do this captive view microscope for brain surgery, real-time imaging to reduce intraoperative disruptions. VR in nursing education is very well accepted. people have been using it for doing VR. Now, because of the cost, there was an issue, but today I think there are now Indian startups which are coming. This is a company in Chennai, which is hardly 4 hours from your place, which is virtual reality in healthcare, medicine VR, and they are now doing with IIT Chennai, and they have created multiple VRs which are very cheap. They are not very costly as we normally would like to buy. So I feel in next few years, we'll be able to get access to this kind of an VR where we'll be able to get much easier education to our students. Apple Pro, Vision Pro has been coming. It has come in USA, not in India, costly. But I'm sure in the next few years, we are not going to have a MacBook Pro. We will have only an Apple Pro Vision, and we will all do the kind of filing and Word through our all Pro Vision. So to summarize, virtual reality is emerging as an educational strategy, as a surgical support tool. Of course, not only in surgery, but also in the many other procedural skills, medicine, ophthalmology, orthopedics, mainly surgical tool, because it has more predominance with the skills. Recent advances in software and hardware have reduced consumer cost and allowed better use for immersion. It is better available today than on an experimental stage. VR is now both accessible and affordable, increase adoption in future. I think as the time will go, more and more people will adopt it. What we really need to do is, VR is currently in its early days, need to determine acceptable risk of real world scenarios to create opportunities. What we really need to do is a proper integration of VR and mixed reality in our curriculums. Now partly it has come. We are experimenting, but partly places people are doing this. And I think this is most important, where we try to take segments of our curriculum where we can use VR or mixed reality as part of their curriculum. This means coexistence of virtual world with the real world. I think thank you so much, and if there are any questions, I'm sure I'll take them.
Any questions from the audience? Sir. If there are no questions, thank you, sir, for the enlightening lecture. Thank you, sir. Question.
Thank you so much, sir. You have shown a lot of articles related to this VR and all. Only one question. Is there any article that published with the limitations and how far it is very close to the a student trained with VR, and while doing a real surgery, what are the difficulties?
See, most of the articles say that it is equivalent in teaching the level of competence you reach. We still don't have articles which say that the patient outcomes have improved because of virtual reality. Now the second point is, if I have trained myself, will I really directly go and operate? No. If you really look at pilots training, they work on VR first, then do few thousand of hours as a co-pilot with somebody, and then they become the original pilot. The same principles follow. Maybe the level of competence which you are entering into the actually real world is better. I'm not saying it replaces your real world training, but currently it will improve your level, and initially, the kind of damages is to caused by if you're directly doing procedure, this definitely reduces those damages to the patient. Okay? Sure. Yes, you have any question? Please.
We were talking about the 3D printing, sir. How far is it useful? Because it can be used only once if I am right.
Yeah, it is. See, there are now in India, there are many places 3D printing is used for, especially for neurosurgery, spine surgery, liver surgery, and dental surgery. I don't know, you've seen a 3D printing. I think I've seen 2-3 3D printing labs in India, and where students really work, they print their tooth. It's only for a patient based. You are learning about one patient. So it costs about 15,000 to 20,000 for a liver. Maybe for dental it costs about 2,000 rupees because it's a small 3D printing. Neurosurgery it costs about 20-25,000. But people are ready to pay for that. That's what I'm saying. It's come into, like in KM hospital, our neurosurgery and liver surgery people use it. If in odd case, especially a vascular case, they use it. It costs, it's only for one use. It's not, 3D printing is only for one case.
Just on the lighter note, quacks now they read about drugs and then start prescribing. Like this, I mean, now they use VR and then they start operating also.
Not necessarily. Will you get operated by them? That's a question you should really ask yourself. I think it's a question of training little better, that's all I feel. So.
Hello sir, I totally agree with you because we have this medicine VR and I've been working with students and I found that retention of knowledge is better when they use some VR. But definitely we will not allow them to go ahead and start practicing.
You should publish. If you have an experience, you should publish because let people others know that there's a better retention.
It has been published sir, already.
Sure, great.
So, and one thing sir, which we notice in the images sometimes it's very artificial. It doesn't reflect the actual image in anatomical images. So there's a problem with that. So how, so any
See, this is ultimately, I feel this is a technology in development. And I think if you see the previous kinds of VR and today's VR, there's a vast difference. In next 4-5 years, I think we will be quite real-like.
Thank you, sir.
Thank you for your doubts.
Sure,
Any other things, sir, will be there to answer it during the lunch. Thank you.
Thank you for that enriching session, sir. Now I kindly request our moderator, Dr. K. Karthikeyan, sir, to felicitate our speaker, Dr. Avinash Supe, sir. Please, sir. Thank you, sir. I kindly request Dr. M. Shanti, ma'am, Professor and Head Department of Pharmacology, to felicitate our moderator, Dr. K. Karthikeyan, sir. Please, ma'am.
Thank you, ma'am. Thank you, sir. For our next session on balancing AI tools with essential research competencies, a critical balance that needs attention, we are privileged to have as our moderator Dr. G. Shivaraman, sir, Additional Professor and Head of ENT at JIPMER, whose commitment to academics and meticulous approach inspires learners across all levels. Sir, we warmly invite you to guide this session and introduce our speaker. Over to you, sir.
Very good morning to everyone. I am humbled to stand before you to invite a very prestigious faculty, Dr. Geetanjali Badnaman. I was her student, I was sir's student, and Madam is now Pro Vice Chancellor in Geetham University, Hyderabad. And anyone needs introduction? She is a faculty of her own words. She is very radical many times, which has helped us to move forward. Honestly, I would say we are traveling in her roads in JIPMER, and we welcome ma'am to this section. Thank you.
Okay. First of all, I would like to thank Dr. Uday Shankar and his team for inviting me here, Dr. Amol and everyone here. It seems good to be back in Puducherry. I'm going to talk to you about a topic which I chose because I'm quite interested in research methodology and teaching research methodology to postgraduates. And I thought this is a good time to discuss how we balance the so-called AI tools which are everywhere and we need to use them too, and how we can use that with the essential research competencies, which I see there is a little bit of a confusion in people's minds. So if you look at the core research competencies of a medical postgraduates, I'm sure all of you will say it's something like we need to know about the fundamentals of research methodology, which would be literature searching, how to write a protocol, how to do some analysis and all that. Critical appraisal and interpretation is obviously very much needed for your evidence-based medicine, and also to look at your clinical work. Ethics and responsible conduct is a large part of whatever research we do. How we communicate scientifically, whether it is written or oral communication, is also something which is one of the core competencies for postgraduates. Statistical literacy goes with it. It forms a part of fundamental research methodology as well as critical appraisal. And then we have the miscellaneous tools, which are, things like team building and all that. It may not be core, but I would say a vital part of the competencies which are needed for a postgraduate. Now, if you ask me, how do we teach these skills? Traditionally, we use these methods. We use journal clubs, we use lectures or workshops, we use experiential training by having a thesis or dissertation done by our postgraduates, and also self-directed learning for postgraduates. So these are the ways in which we teach these competencies. Now I'm going to focus only on journal club just to use an example for my talk today. So what are you expected to learn during a journal club? Anyone? What are you expected to learn during a journal club? Okay, no one will answer. Everyone is scared to answer in my classes, I guess. So, first thing is you are taught how to select a paper, isn't it? A good topic, sometimes you sit with your guide or whoever is the moderator. Can you actually present a paper? I mean, I would not present a paper from, let's say, Journal of Physiology, because I'll drown in it, kind of. So, you'll want to, do something and select a paper which your department people will like to have. How you critically review it, of course, all these things, no? How to present, how will we present the inconsistencies properly and things like that. Then, of course, you learn how to answer questions. People will be bombarding questions. Sometimes you also tell your co-PGs, don't ask any questions, those kind of things. So, how to think on your feet, how you will do clinical reasoning, how you learn from this. And again, there is another miscellaneous this thing where apart from the core knowledge which you learn from the paper, there are other things which you learn during a journal club. So journal clubs are actually, it's a very vibrant kind of teaching learning environment for research methodology, especially for postgraduates, and we all agree to that. But if you ask me, what is the most important competency which is imparted, I will say it is critical appraisal of a paper. Agreed? Yes, okay. So now we are having a tool which just does that. See, we were trying to say that during journal club you have to know how to critically analyze a paper, but we have something which is doing exactly that. So how many of you, the postgraduates who are sitting there, if you don't mind, look at me, not at your laptop, but can you tell me how many of you use AI tools to help you in your journal club presentations? Anyone? Can I see a show of hands? Nobody? Seriously? Yeah, I can see one hand. Thank you. You're not postgraduate. I'm asking the postgraduates. I can see only one hand. I'm really surprised. Because I know I think at least 90% of the students are now using AI tools for some aspect or other. Okay, maybe you don't want to be truthful. That's okay. So what I did was I used this paper. It's a paper which was published some time ago, and I asked ChatGPT to critically analyze this paper. Okay, and this is the prompt I used. Can you critically analyze the paper, turmeric tonic this thing, and give your comments? Slides are not moving. Sorry. Oh, slides are not moving, huh? No one told me that? I'm sorry. Slides are not moving?
Just remove this and put it.
Oh, we skipped so many slides. No, just go back to the previous one. Okay, then I have to move it with this. I think I can't use the, yeah? Yes. No, I don't want that. Right, okay. So this is this was the paper, turmeric tonic as a treatment in scalp psoriasis. and I use this prompt, okay? Can you critically analyze this paper? And so, ChatGPT immediately within a few seconds, it came up with this. It said it is a appropriate gold standard, that is a study design. It said that, they used this in moderate to mild psoriasis and they used validated outcome measures. Then it spoke about the strengths of the study. It said that there is a rigorous methodology they have used, very clear clinical endpoints, no adverse effects, but it also said limitations and areas of concern. It said it has a small sample size, formulation undefined, short duration, no follow-up, population specifics lacking, and so on. So that is something during journal clubs we want some limitations which postgraduates generally would like to list. And then of course it said overall interpretation, even though there is a small, it is a small size, no head-to-head comparison and all that. It also gave its own recommendations, okay? It said that you need to enroll more than 100 patients, and it said you need to have a standardized formulation and so on. So what it gave is enough for a postgraduate to present in a journal club, obviously. But to be fair, I also ran it through Perplexity and Gemini, and I got almost the same comments. So then what I did was I decided to review it myself, okay? So I thought, let me try and review it, and when I reviewed it, I found in the abstract it said, the aim is to investigate this as an immune modulation and anti-inflammatory therapy on scalp psoriasis. But in the introduction, it says we want to evaluate the clinical effects of turmeric tonic in these patients. So there is obviously a huge mismatch. Second thing is, I saw that in this, in the methodology, it was clear that it didn't say anything about generation of sequence. Sequence generation was not mentioned. It was by the pharmaceutical company. It actually said only for the tonic it was done. And there is nothing about the blinding, which you know is very important, especially in a RCT. Nothing about the sample size, estimation or anything like that. And then when I looked at the results, if you saw table 2 and table 3 had identical headings. Okay, the legends were identical, but what was in it, the content was totally different. Okay, and then when you looked at the primary outcomes at week 3, it said it was, P is less than 0.05. But actually, if you looked at the figure, it was exactly the same. Both the values were exactly the same at week 3. So there was a misrepresentation of the results in the figure as well as what was written in the text. Then of course the conclusion said that there was no long-term adverse effects, but actually the total duration was only 9 weeks. So now none of these 6 points were pointed out by AI, okay, which I pointed out. So now, do you still think that these AI tools can be used for critical analysis? What do you say? No? Yes? That gentleman who uses AI for your journal clubs, do you say yes or no? Yes, with a pinch of salt? Okay. Now I would say not yet. See, these tools are improving all the time. They may not be fine now, but certainly within maybe a year, it will be much, much better. So then what I did was I rewrote the prompt. And I said, was the paper this reported as per the latest consort reporting guidelines? Now those of the clinicians here, you will know RCT, we use the consort guidelines to write or report the paper. So I asked it, was it reported as per consort guidelines? And immediately it said, no, it doesn't fully conform, right? And what it said was, what it didn't know was it said that it sort of said consort 2010 is the latest, but I know that the latest consort statement is April 2025. I had gone through it. So if I didn't know that the consort statement was updated in 2025, I would still think 2010 is the latest. So then when you look into the comments given by ChatGPT for this prompt which I had written, it gives much more information, okay? It says randomization, sequence generation, allocation concealment details are missing. It says sample size was not. So many of the things which I could spot, it is also doing, okay? It talks about the statistical tests. It says there is no consort diagram, the flow diagram is not there. So many things which it didn't say initially, it is now saying. Why? Because it is using the consort statement, even though it was using 2010, it is still very, very valid. So, in order to get better information, you need to keep improving the prompt. And to be able to improve the prompts, you actually need to have the knowledge and feed in the correct phrases. And this is what I think Avinash and guys were telling yesterday, because you need to keep on torturing the prompts until you get the information you need. Right. So this is a common problem with all information retrieval tools. It's not only happening with these AI things, because if it is all designed to respond to specific queries, and unless you ask the correct question, you're not going to get the correct answer. And the context is crucial. See, apple may be only this apple which we eat for us, but if you put in the word apple for AI, it might mean apple as a company. It might not mean the apple which you think in your mind. So you need to be aware of the tool's functionalities as well as the limitations. And that's where we sort of go wrong. We give it too much importance. And therefore, we also need to critically evaluate the results. You can't take the results at face value. So even though the tool provides access to information, the user's knowledge and ability to formulate the appropriate questions, this is essential for effective information retrieval. So this is for all tools. And if you don't know this, you will miss, okay? So it's quite clear that you need to have this basic knowledge in order to keep asking the right questions. Now, what will happen if critical analysis skills are not used regularly? I am in my sunset years. If I don't keep looking at papers, if I don't keep critically analyzing, what do you think will happen to my faculty? It's easy. Use it or lose it. It's just like any other muscle. If you don't keep moving, you don't keep walking, you are not there anymore. So this is known, and this is where we senior people at least fear, because if you are not doing it well, then the chances are, if you don't practice, you may not be able to do it at all. So you need to keep using it, and there is information which is coming in. See, please remember, these things are only from 2022 onwards. Therefore, I mean, it started much earlier, but these kind of tools which we use have become very prominent only after this ChatGPT became very prominent and being used so easily, this generative AI. And we really don't know how it will affect our, critical thinking ability. So be a little careful. See, the older generation got it right. And they knew that how important it is to keep the mind and the fingers and any skill to be good, you need to be at it. They simply got it right. So if you ask me what needs to be done, I will say we need to integrate AI into the very manner in which we teach research methodology. So this is for all the educationists here who are postgraduate teachers, who teach postgraduates. We can't leave it aside, we need to integrate it into the way we teach research methodology. So what can be done? First is you need to understand AI as a research tool. It is an important tool. We need to know a little bit about how the algorithms work, how to select the appropriate AI tools for research tasks. For example, if you want to do a literature search in medical sciences using AI, these are some of the tools which are commonly used. So there's no point in using a wrong tool and saying we didn't get it right, because there are tools which are specifically designed for this. For example, if you're doing imaging or omics, these are specific tools which do that, okay? or if it is statistical tools. I met a friend of mine who said after Yamovi, I don't know why I spent so much of time learning SPSS. Okay? So these are tools which are very, very easy to use. But in interpreting the outputs, you need to be very critical and skeptical. You need to be like me and Ravindran, I would say, always questioning. Okay? That mindset you need to have, and you need to understand the limitations. So that's important. There are a lot of beautiful tools you need to choose, and you need to know how each one works depending on what you want, your output. The second thing what can be done is you need to maintain core research skills. You can't say that now that AI is there, I don't need to know how to do statistical tests. You may not know how to, what formula to apply, even I don't know. But you certainly need to know what it means. So you need to, so for example, if it is literature review, I don't say go to the library and look over it, no. But if you are using Mendeley or some Zotero, you need to be able to do a good critical manual search. That is what we call manual, and see how the AI assisted methods match. You also need to cross-verify the results with the traditional methods. This is something we've been saying. And then it is there to augment and not to replace the research thought process. The third thing is, of course, ethics. And this is certainly something which is easy to cross the lines because the lines are blurred. So we need to identify these bias in AI models and ensure equitable access. This is for all teachers, especially for administrators like us. And then we need to understand the ethical and legal implications of AI-driven research. Many students are going into it because it is easy. They don't want to go out into the community, collect data. They don't want to go out into the hospital or collect data. Okay? We need to understand data science and the basis of informatics. I'm not saying go into real depth, but you need to know that if you use large data from the internet, it also has to be cleaned. You also need to, this thing, because you need to understand how important the quality of data is and the provenance. That means what is the source. If you don't know that, it is better you don't use that data. And lastly, the rules of communication, whether it is written or if you are also giving a talk, you'll need to know what are the, what are the limitations of this, and to collaborate with these people who are data informaticians and ethicists. So the strategies to achieve this critical balance will be obviously hybrid learning approaches, which is what we use commonly now. Most of us use these approaches for teaching research methodology, and you need to ensure all your postgraduates are also technologically competent. They are also fluency. Tech fluency is very, very important nowadays, as is the foundational skills. We can use interactive problem-based learning, which will be much more interesting for the students and also will get them to critically start thinking and about independent decision making. I would suggest if you are using AI for assessment, use it for your continuous assessment, but your summative assessment, there has to be a little bit of critical appraisal. It has to be manual. Otherwise, you wouldn't know whether they know the basics. And then, of course, we should use it. We should train doctors to use this. Faculty development and institutional support is very vital for this. So, for example, if somebody is doing research on, let's say, pathology, and they are using AI to scan the slides, they may not know how accurate that is. So students should learn to question the underlying reasoning. That's very important. And also, if you are doing AI literature review, assisted literature review, just like what I said, manual review is critical for context as well as the nuance, and of course data analysis. This is great in identifying patterns in large data, but the interpretation and hypothesis testing is obviously a very human responsibility. So if you go to this site, Sakana AI, this says that it is a website where fully automated pipeline for end-to-end paper generation. it will generate the idea, it will do the experiments for you, it will write the paper, and it will also review the paper. So, sitting right here, you can do your entire thesis. You don't have to even think, okay? Now the issue here is, as a medical educator, we need to know that, see, so if you are looking at literature review, yes, you should have these AI-enabled skills, how to do a search, how to summarize, but critical appraisal belongs to the human skills which you need to develop. Protocol generation, data mining, certainly AI will do it for you, but the hypothesis formulation, seeing whether this is ethically correct to use the kind of data and things like that is human. Again, data analysis. You can easily do data analysis using these programs, but the reasoning, interpretation remains essential human skill. Similarly, when we scientifically communicate, it can make drafts, it can make your slides, but the argumentation, peer review should be a human skill. And similarly for ethics and legal aspects, contextual judgment and consent always remain a human skill. So as an educator, I would say guide students in contextualizing AI outputs, provide mentorship when to trust, when to question, and when to override the recommendations it is giving, and teach them to use it as a collaborative tool, not a replacement, and then maintain human oversight to ensure research integrity. So use AI for critical thinking. So the kind of experiment I showed you, which I did, I would now, if I were a student, PG guide, I would ask my students, can you reflect why ChatGPT generated that response? What assumptions was it making? What is it missing? Or did I miss something AI did not? So you can start them thinking about it by asking them these questions, and that is, I think, very essential. So my final thoughts are, we equip our postgraduates to harness AI, its strengths and capabilities, continuously hone the essential research competencies. Technology should be an enabler, not used as a crutch. So AI tools are going to be here to stay, but believe me, they are getting better by the minute and the day. So it will get better. And so therefore you need how to use this to get the best output and know its capabilities and limitations, and traditional skills like critical appraisal, interpretation of findings, they are still important and crucial for quality research. And there is evidence that AI may accelerate skill decay and hinder critical thinking, especially when there is excessive dependency on these tools. So that's for us to decide whether your postgraduates are excessively dependent on these tools. And of course, technology should be used as an enabler. Thank you very much, and I'll be happy to answer any questions.
Thank you, ma'am. That was a brilliant teasing out of the balance between using AI and the old system of using the human as a tool for research. Anyone has questions? Sir.
Don't allow questions from Ravindra, na?
As you rightly said, but then you didn't use the exact words. You use AI as an assistant. You can't take decisions, you can't allow AI to take decisions for you. Agreed. That means you should know the subject. You should be the master of the subjects, and it should help you. And you should know whether it is making it is making sense or not. That is if you use it as an assistant, then there should not be a problem in using AI, any of these things.
Yeah, so I never said that it is wrong to use it. Yeah, of course we should use it.
Exactly. Even the first one now, the criticizing the papers. See, there are two things about the criticizing the papers. One is criticizing the presentation. What is report? Criticizing the report that appears in the journal or some this thing. Number two is the criticizing the work. Whether the methodology, whatever they used and all those things, whether that is right or not. Whether the model they have chosen, whether the animal they have chosen, or the human subjects they have chosen, whether that is right or not. That is concerning the work. That is one aspect. The other aspect is whether reporting any mistakes in the report. any mistakes in the report can be, rectified, but then, any flaw in the work, that cannot be this thing. But whatever you have shown, the AI is not good in, maybe, if you give a guide, that is, if you give some guidance to the AI, it will report that, no, these are the flaws in the, as you said, ComSat. Use a ComSat checklist, it will immediately find out, oh, this is not that, that is not that, that is not there. But then there may be a major flaw in the methodology that I don't think, AI will be able to point out, at least today. As of today, it won't be able to point out. But then the humans, if you are an expert, if you are expert in the field, and in that field, with one look, you will be able to find out, no, there is a major flaw in this one, and you are not going to accept it. So, only, if you are, good, you have expertise, you can use it, and you are, a bit lazy to, do the work, you ask AI to do it, and then, you manually go through it, correct it, and do. That is how I use it.
Thank you, sir. Good point, well taken.
Yeah, ma'am, thank you, ma'am, for your nice talk. It was, actually, ma'am, what I think is just my suggestion that prompt is very important, what prompt you are giving to AI. Because AI behave according to the prompt. If you change the prompt, everything is different. AI is very good, and if our prompt is correct, we can get approximately closer to our own perception. And if prompt is completely wrong, then definitely it will take you somewhere which you will never land. You will land in the moon instead of landing into some other country.
Yeah, but to know whether it is close to what we want, we need to know that, isn't it?
Yes, yes.
So that's the whole problem.
Yes, ma'am.
See, you need to have some knowledge for you to know whether what it is telling you is right or not. So both are needed. At the moment, both are needed. Nobody is saying that this, like they say, you torture the prompt to bring out what you need.
Yeah.
I fully agree.
Yeah, thank you.
Thank you very much, ma'am. After hearing your presentation, what I think is hereafter we should train PGs or faculties to criticize the AI outputs. They should find out the mistakes of AI. Thereby we can, enhance our real intelligence. Okay.
Okay. I don't know. We are going in a very taking a difficult path. What is the need for that? If you really can do
by doing this, when you report back the mistakes of AI, AI will improve.
But then you have to feed it back.
Then we can use the product reliably, no?
Okay, then you have to feed it back to the AI.
Whatever you find, of course you have found so many things in your the journal article you have shown, so you should report back.
Yeah.
So this is the exercise we can use positively. Thank you very much, ma'am.
Thank you, ma'am. Thank you so much.
Thank you for that nourishing session.
Sorry that my slides didn't move. You missed
That was only a 20
3-4
seconds.
slides. Anyway, it's
10 seconds.
Now we kindly request our moderator, Dr. G. Shivaraman sir, to felicitate our speaker, Dr. Geetanjali Padmanabhan ma'am. Please, sir. Thank you, sir. Now I request Dr. M. Vimal sir, Professor of Pathology, to felicitate our moderator, Dr. G. Shivaraman sir. Please, sir. Thank you, sir.
We now welcome Dr. S. Asmitullah sir, Additional Professor of Biochemistry at AIIMS, Madurai, a passionate educator known for his clarity in teaching and encouragement of student-based learning, to moderate this session on technology and professional identity, transforming roles in the digital age. So we humbly request you to introduce our speaker and moderate this session. Over to you, sir.
Thank you, ma'am. Good afternoon, all. I'm very happy to introduce the next speaker, Dr. Himanshu Pandya sir.
currently working as a Dean of Pramukh Swami Medical College, Baikaka University, Gujarat. Sir is a Lifetime Achievement Awardee and delivered the Dr. Rita Sood Memorial Oration in MU India. And he is the founder convener of Nodal Center for National Faculty Development Program. An area of interest is Faculty Development Program, Professionalism and Professional Identity Formation. I am very happy to chair this session because when the CBME was introduced, when the FDP programs were conducted, when we were in APs, really I was surprised, okay, somebody is there who is reading the science of medical education and trying efforts to deliver this science of medical education to all the medical educators of India. So I was not expecting that I will be seeing the sir, and thank you so much, sir, for delivering science of medical education to throughout the India. Thank you so much, sir. Over to you, sir, next.
So here it will not be in slide. Can I have? Yes. Yeah. Thank you, the organizers, for inviting me to talk on this subject, combining technology and professional identity formation. Over the next 25 minutes, I'm going to talk about a subject which is something which is a discourse which has started about 30 years back from professionalism. Over the last 15 years, this discourse has moved to what is known as professional identity formation. We heard from both Avinash and Gitanjali about the use of artificial intelligence and the pitfalls. Now, in the session, we are going to talk about how do we ensure that technology brings us closer to patients and not further away. So, in this session, we are going to talk a little bit about professional identity, but it has to come from the domain of professionalism. We'll examine digital transformation in medicine, apply the conceptual framework of deep medicine from Eric Topol, and offer some of the strategies to guide identity development in the age of AI. If I ask somebody in the audience, what do you exactly mean by medical professionalism? It may appear to be abstract to you, and sometimes people have answered that I cannot define, but I see it when it actually is demonstrated. There are many definitions of professionalism in medical literature as well as social science literature. This is something which is coming from Cruez and Cruez from McGill University. It's a Venn diagram which is trying to explain the attributes of medical professionalism. When we were practicing medicine more than 2 centuries back, we were more of healers rather than professionals. And with the advent of biomedical science, we became professional. Also with the institution of institutions and licensing bodies. I would particularly like you to look at something which is common to both attributes of healer and professional, right? What is important here is, some of the, attributes of being a compassionate physician. Another definition which came from Arnold Stern is like a Greek temple where, there are foundational elements of clinical competence, communication skills, understanding of law and ethics. These are foundational elements necessary but not sufficient to be a professional. And then you have what is known as aspirational elements of, which are principles of professionalism like excellence, humanism, accountability and altruism. This is something that you continue to strive to achieve over lifetime of your being a medical professional. This particular framework is also used for assessment of medical professionalism. Somewhere around 2000, 2010, another group gave a different view of what is medical professionalism. They came out with the concept of behavioral and system view of professionalism. Now, when you say behavioral view, it was said that professionalism is not something which is a character trait. It's something which is observable, something which is measurable. And when you say system view, it is something which doesn't happen in isolation. It happens amongst, the physician and patient interaction happen in the midst of interaction within the care team, within the systems and within the policies created by professional bodies and regulatory bodies. And there is a reverse relationship, the kind of system that you have, the kind of policies that influence how you express professionalism, and also the fact that you have a responsibility to influence professionalism. Now, I said that over the last 15 years or so, the discourse has moved to professional identity formation. So, the group which came out with the concept of systems and behavioral view based their, conceptual framework on what is known as physician charter, because that is something which has been widely respected as a definition of professionalism, and based on which they came out with certain observable behaviors for practitioners and also for organizations. Right. This is the article which is coming from the group which was tasked by Carnegie Foundation for Advancement of Teaching. Like the seminal report of Abraham Flexner, this is another report which came 15 years back. Abraham Flexner wrote his report in 2015. This has come in 2010. And it argued for one thing, and that is that the medical schools or colleges have the responsibility not only to impart knowledge and skill, but also to support professional identity formation. And that is the job of medical schools. Now, what is professional identity formation? It is an adaptive developmental process that happens simultaneously at two levels. One is individual, which is psychological, right? And the other is collective, which involves what is known as socialization. Socialization in the community of practice. So that a person comes to have appropriate roles and forms of participation in the work of community. Now, there are various factors which influence how your professional identity develops, and it is based on your experiences with your role models, your mentors, also your your also what kind of clinical and non-clinical experiences that you get. And the kind of roles and responsibilities that you take also depends upon the kind of teaching learning environment and also the practice environment. And this is how, your personal identity blends into your professional identity. So, becoming a physician involves more than acquiring skills. It is also about becoming a professional. And it is about internalization of values, norms, behavior and expectation of society and expectation of the profession. And as I said earlier, it is influenced by role models, experiences and institutional culture. Now, we are moving to what is known as digital shift, and that is what is going to affect our professional identity. The question is, how does the integration of technology, especially AI, reshape how future physicians will see themselves and their roles? Deep medicine is the path to making healthcare human again. There is an argument that, the question is, will AI replace physician? The answer is, physicians who use AI will replace physicians who don't use AI. AI can restore time, empathy and connection. It can let machines do what they do best. So humans can do what only humans can. Humans can be compassionate, humans can be empathetic. So there are 4 elements of what is known as deep medicine. Now let me explain the concept of deep medicine against the concept of shallow medicine. All of us know, particularly those who are using electronic medical records, we have electronic medical records at our hospital, and there is a problem that most of the time the physicians are focused on the computer rather than the patient. The time available for patient is reducing. AI is going to ensure that that time will be shortened, and you will have more time for your patients, for listening to them, listening to their complaints and even counsel them. So these 4 elements of deep medicine are empathy restoration, time liberation, augmented decision making and rehumanization of human care. So those of you, if you are worried about, AI replacing you, no. We are going to be helped by AI if you use AI as assistance, right? So it is going to be a force, and it is going to be force also in shaping our identity. Digital platforms and virtual tools are not just tools, they will shape how future physicians will see themselves, what they value, which is efficiency, precision and availability, how they relate to patients, peers and profession. Now, look at this particular table, right? You have the PIF elements here, the identity and roles of the physician. You have the influence of digital medicine and how deep medicine is going to respond to these issues. Because of algorithmic support, there will be focus on interpretation, not just input. There will be focus on reclaiming empathy through AI-enabled time. AI will give you time to be empathetic to patients. Reflection. There will be digital platform for reflecting. Use AI prompt to deeper and personalized reflection rather than superficial reflection. Mentorship, you will have virtual learning and you will have access to global role modeling and connected mentorship. Now, there is a possibility that technology can dehumanize if there is diminished face-to-face mentorship, burnout due to digital overload, threat of click-and-go medicine, and risk of identity erosion. Now, AI is something which can rehumanize. We have to preserve our touch. AI can give students more time to reflect, converge, learn from patients. Technology must support, not substitute, professional growth. Technology will have several elements as a mirror, as a mentor, modifier. It will reflect the evolving roles that physician will have. It will guide through data-driven feedback. It will actively shape self-concept. What is identity? So use tech to amplify humanity, not automate identity. Social norms are now getting shaped by various AI tools. Now this is going to be a new hidden curriculum. Will we, go for speed over depth, productivity over presence? Presence is what is very important. Presence to your patients. And presence means listening. Presence means touching. Presence means empathizing. So you have to counterbalance AI with intentional design inspired by deep medicine. So you align tech with identity formation, reinvest time saved by AI for human interaction, use simulation and VR for perspective taking, use AI case discussion as part of identity formation, encourage narrative competence through digital platforms. What should never be automated, right? What parts of your professional identity must remain fully human? If I have to answer, they are empathy, moral judgment, presence, listening. Let us protect this by conscious design. Okay, designing learning environments. These are integrated AI tools with human mentors, reflection journals with AI prompt, faculty commentary, storytelling through multiple media. Faculty do have a role, and that is to be models of ethical AI use. Demonstrate presence and empathy, even in virtual spaces. Encourage critical reflection on tech's role in the profession. And if you reimagine physician identity, you have to be a data custodian. From data custodian to data informed healer. You have to move from expert knowledge base to empathetic interpretation of knowledge. And deep medicine is going to be new archetype. Digital powered, empowered humanist. Right? In what ways technology already has shaped your vision to be the kind of doctor you want to become is the question. Right? And my argument is that AI, if used judiciously, is going to help us rehumanize medicine. Thank you.
Thank you so much, sir, for giving the insights of how the technology can be used to build our PAF and what are ways that we need to prevent when it starts dehumanizing our PAF. Thank you so much, ma'am. Any questions from audience side?
Thank you, sir, for your great talk. In just connection, what I learned from the previous talk and what I got from yours, that for any meaningful learning to happen, we hope that student has some memory. They have capacity to hold that words and concepts and ideas and use that for thinking later. The second thing is that the longer learning curves work, that if we quicken the learning process, then perhaps student will forget the lesson learned. So keeping that in mind, we see the problem of less attention spans in the classrooms. The most of the innovations that are happening is to quicken the education and make things more instant. And I fear this will cause long-term, irreversible and serious damage to the critical thinking. But what I learned from the comment of Ravindran sir, who said just in comment to the previous talk, I am just hypothesizing that AI tools will give better identity formations at the hands of experts. But AI tools, if used uncontrolled, in uncontrolled way, among novice learners who are yet to understand the vocabulary of profession, perhaps would end up with this consequence which I just mentioned. So I think that opens the area of big research for us to see that we have both pros and cons to look at it.
Yes, this is something which is going to be an area of concern, also area of research. Because, the technology is coming to play its part in medicine in a very, very deep way. And it was very obvious from the earlier presentations that, it is essential that as educators we are very conscious about these and ensure that the student don't lose their ability to think critically. So that is going to be a very, very important job to do. These are the tools which we have to use as assistant. They cannot control human thinking. Yes, madam.
Thank you, sir. From, as Dr. Amol was telling, from both your presentations, we understand that we need to create content also for AI. Because unless AI has a proper content, and it won't be giving us the right input when we seek its assistance also. So maybe that opens another avenue that as professionals, we also should be able to be creators, and we have to train AI as well. Apart from our students, we have to train and create new formulations for AI so that it will help the future generation as a good assistant. Is it?
So it is also what AI tool you use and how up to date that AI tool is. And as has become very obvious, we probably have role to ensure that AI also becomes smarter by our inputs.
Yeah, what in a way it is true. I recently read a report, the AI has given a new insights which humans have not thought of. But then mostly that knowledge, AI knowledge also comes from the human knowledge only. Whatever the knowledge has been accumulated, whatever the information has been accumulated, this all AI reads and then it produces content. Mostly it is repeating the content in a better way or some this thing, in a structured way or in a way which is easy for us to understand. But it is also reported that it is giving some new insights also. Sometimes it is it might give some new insights. Suppose we have let us say we want to do something, and then we know 10 ways to do it, and we want to know whether there are any more ways to do it. Then you ask AI might suggest something which we can use it in this thing that might improve our work. That's how we can use the AI.
So it is likely that some of us in medicine have a role to play in improving the prompt engineering. This is what I think.
Sir. Sir, as I said, the AI can rehumanize the use of words. By use of words, they improve the communication skill. But the AI tool has a limitation that they cannot read body language. They cannot see us. They cannot perceive the touch of a doctor benefit to a patient. So we can better train to talk. So the real touch remains level high always.
Absolutely, there is no doubt about it. What AI is going to do is, there is this voice to text transformation, right? You will have less time that you will be using for recording the data. AI will also help you in diagnostic reasoning. AI will also help you in formulating plan of treatment. These things will help faster. You will have more time available for your patient, to listen to their patient, to consult them, and that is what is the argument.
So actually, I fully agree with Soumya ma'am. The most important human fallacy is to analyze large data. So I can analyze data which is concentric to me, or sometimes I can analyze data which is eccentric to me, or like I want to find out a data on when to do a tracheostomy for a tumor of which size I have to do. So I actually searched in Google PubMed some 20 days back. I couldn't find proper data on it. But when I put it in a Research Rabbit and LitMap, it immediately gave the data to me. That's only, I searched it for 2-3 days. It came through proper channel. The resident searched it, then one more assistant professor reviewed. Then I had the opportunity to review the paper. Now, we didn't have data in PubMed, or we didn't search properly, that's what I would say. But when we searched the correct research question, the AI overcome the human fallacy. So we should use AI only to, it will only do a better job in human fallacy, but not in creating the real content has to be somewhere, and it has to be uploaded in the internet also. Then only the AI can actually generate data for us. That's one. And another important thing, as Sir said, there is something called prompt GPT or meta GPT. It will actually iterate multiple times the prompt. So it has come up already last 6 months that has been launched. It will generate the prompt for us. You should see how it generates prompts. When it generates prompts, I actually learn from the prompt. So it's only the human fallacy of not learning the large data which is overcome by AI, but not the real human potential can never be taken by AI. That's what is my...
Sure.
See, the AI, I think the one problem with AI is, people say that, they found out, or maybe, the AI is working as if, as the brain works, like brain works. I don't think so. Nobody knows now how the brain works. But then the AI works, based on mathematics. Even the large language models, everything, it's all based on mathematics. Yeah. They use statistics, linear algebra, and optimization. These are the 3 pillars of AI, and it's all fully mathematics. I'm not sure that our brain works based on mathematics. That there's a problem with AI. Definitely there's the difference how AI works and then our brain works.
Yeah.
Just a comment, Dr. Pandya. Thank you for that wonderful talk. But already, as you said, this text to language to text models have come into the OPD.
Yeah.
So they just keep a microphone. You take history that is transcribed as your case record, and it's also giving you the differential diagnosis. It's giving you a provisional diagnosis and all that. It's already being done in many colleges, including some of the new AIMS have also adopted it.
Okay.
So the question is, what are you going to teach your students? How to take a history, write a history? Because all that is history. You don't need to learn these things because AI is doing it for you. So we, as teachers, we need to keep on adapting to this.
Absolutely.
And this thing question whether this saving of time, when you are writing something, you are saving time because somebody is doing it. is going to extrapolate as more time for the patient, more empathy. That is a question, huge question, needs to be answered.
Yeah.
Because even way back, some decades back, this Maxwell wrote a book, Gladwell. He wrote a book on David and Goliath, saying exactly these same things. Whether a small number of students will improve the teaching, and nothing is proved. It couldn't be proved. So it's a multiple complex decision, which already, there are so many examples where we think it will work, it has not worked. So we think people will use this time to show more empathy and things like that. Whether it is going to happen or not, we have to wait and see. So it's just a comment I want to make. Thank you.
Oh yes, I also reckon that not only you will have time for your patient, you will have time for your students. And you will have more time for guided reflection. This is what my take is.
Thank you so much, sir. Thank you, audience, for asking questions. Thank you for the enlightening, sir. We kindly request our moderator, Dr. S. Asmutullah, sir, to felicitate our speaker, Dr. Himanshu Pandya, sir. Thank you, sir. We now request Dr. V. Deepika ma'am, Associate Professor, Department of Physiology, to felicitate our moderator, Dr. S. Asmutullah, sir. Please, ma'am.
Thank you, ma'am. Thank you, sir. So there's a small challenge for all of you gathered here. A QR code will be displayed on the table, on each table. So it will contain, once you scan it, it will contain 10 multiple choice questions. So you have to attempt all the questions, and the person who attempts it the fastest, ma'am? The person who attempts it the fastest with the most accurate answers will get an exciting prize at the end of the day. So we kindly request everyone to participate in this challenge. And we'll be displaying the visual chronicles of MAU here at SMVMCH and diaries, which are nothing but voice of transformation over the years. So kindly have a look. And
we now break for lunch. Lunch will be served at the back of the auditorium, and kindly rejoin us by 40 minutes.
It's our pleasure to welcome Dr. Himanshu Pandya sir, a visionary leader and Dean at Pramukhswamy Medical College, Anand, Gujarat, known for blending technology seamlessly with medical teaching. To introduce our guest speaker and moderate this session on a critique of AI in medical education. Please, sir.
Very good afternoon. It's indeed a pleasant privilege to introduce to you Professor Janet Grant. Professor Janet Grant is an eminent educational psychologist and presently holds the position of Director of CENMEDIC, Center for Medical Education in Context at London. Professor Grant's work continues to influence education policy practice worldwide, and that is how she is a leading figure in advancement of contextually relevant medical education. She also holds honorary professorship at the University College London Medical School and is also Emerita Professor of Education in Medicine at UK Open University. Professor Grant also serves as a special advisor to the President of World Federation of Medical Education and has been instrumental in shaping the global standard for postgraduate medical education. Professor Janet Grant.
Hello, and thank you so much for inviting me to speak at your meeting. I wish that I could be there to talk about these really important issues. Because I'm going to be giving you a critical view of AI. So let's begin. As usual, I have got some questions about this whole field. Why on earth is everybody talking about AI? And what do you think is actually the purpose of education, and how does that relate to AI? Have you analysed the effects of AI on learning? Is talking about AI stopping you from talking about things that are really important? And what about AI and the planet? And who controls AI? And is AI just the new moral panic? Wherever I look, AI now is the only topic of conversation in medical education. That's really worrying. Has everyone forgotten what they know about learning and teaching and educational planning? The method, and AI is just a method, should never, ever come first. But suddenly, it's papers, it's reviews, it's books, with the inevitable conclusion, of course, that more research is needed. It's conferences, just like this one. It's there, replacing teachers. It's even a human interaction substitute. You can be made to feel that you're talking to a human, but you're not. It's a writing substitute, as you know, I'm sure, from some of the work that your students might submit. It's replacing communication skills. Instead of you having to think about communicating your ideas more clearly, why not use the top 10 tools for paraphrasing? But please, don't. Just don't. It can, of course, be a clinician substitute, making diagnoses. It could be a researcher substitute in scientific research and writing. And many publishers now have policies on this. That is really, really worrying. And the advice mainly says to avoid using AI in research. And some people present it as a thinking substitute. You don't now even have to think of the question to put to ChatGPT. It's got a lot of prompts for problem solving. So it's a learning substitute, and that is the most worrying thing of all. The UK Higher Education Policy Institute has completed a survey about the use of large language models of AI and found that 92% of students are now using AI in some form, which is up from 66% in 2024. 88% have used generative AI for assessments, up from 53% in 2024. And it's mainly used for explaining concepts, summarizing articles, and suggesting research ideas. So really, you don't need to use your brain anymore. And 18% of students have included AI-generated texts directly in their work. I am really worried. We have suggested curricula for artificial intelligence. Let's treat it as though it were a subject worthy of study. How on earth has this awful, worrying situation happened? Well, there are so many AI evangelists trying to impose the AI message on you, making you feel just that little bit old-fashioned if you don't embrace AI. Resist. When there are powerful influences like that, with no evidence, and vested interests such as marketing or academic standing, and product evangelists trying to make money out of you, particularly in an area like education which has no robust evidence base, that mixture of forces becomes dangerous and it dominates the agenda, causing moral panic. You feel, oh, I need to get involved in this AI thing because everybody's talking about it. Resist. If you just look at LinkedIn, you would think there was nothing to talk about except AI anymore. So this is moral panic at work. It creates this widespread worry about the values and principles which society upholds and may be in jeopardy. So there is a creation of a concern, often driven by the media, often lacking evidence, and growing concern about the group or the issue. Are we using AI? The big concern is, how are we going to use AI? We should be using AI. What will AI be doing for us? And consensus on a need for action. How is medical education going to use it? Let's think up models. Let's write books. And suddenly it's all disproportional. And suddenly the agenda is controlled by people talking about, in this case, AI, with a volatility of focus around it. How are you going to use AI? Where are you going to use it? What are we going to do about it? What's the best way? And people become more and more concerned. There have been waves of moral panic in medical education always, for as long as I've been around, in all these areas. Medical education not being a discipline, not being an area which is founded on knowledge and research, is ideal for moral panic. So medical education has got very, very involved with all these different agendas, and at any one time you will find that they dominate the conversation, and all the conferences and books and papers are about this. And that has happened for as long as I can remember, and I can remember a long time. And now the latest moral panic, the latest thing we have to think about, which pushes everything else out, is AI. But panic is not thoughtful. So please stop. There are some serious issues. The most serious of all for me is about the effects on learning. So when you're reading what your student writes or hearing some opinion they produce, do you know that student? Or do you know the AI that they are using? And can you tell the difference? Telling that difference will involve you knowing your student even better than you did before AI, so that you can judge whether or not this is something that the student might have said or thought. And then if students are using AI, every academic institution is going to have to think about its definition of plagiarism. Plagiarism, where people use ideas that are not their own and pretend that they are. And using AI is a form of plagiarism. You will need to rethink that. Professors lose their jobs for plagiarism, and students lose their progress for plagiarism. So the effects of AI on learning are already beginning to come out. The permanent training wheels of AI inhibit student learning because students become over-reliant on shortcuts, on AI to just give them the headings for the essay, on AI just to summarize the field. It damages their academic and cognitive skills acquisition. So if technology is used to cognitively offload tasks, that will hinder their learning. The only way you can learn and learn to think is by using your brain, not by using a computer program. AI has a de-skilling effect on humans. Someone who relies on AI can only ever practice formulating a question, never applying purposeful, critical thinking to answer it. Those of you who are older, who've been through the non-AI education and professional processes, you're fine, because you've learned to think. Although you can lose that quite easily. But your students who have never been through the same education as you will never learn the critical thinking that you have learned. If a learner does not have to practice the fundamental processes of learning, searching, arguing, evaluating evidence, memorizing, problem solving, organizing information, what sort of professional person are you producing? And then, is this AI that people are beginning to rely on always right? Well, you know it isn't. You know that there are concerns about bias, that they reproduce the biases that we have in society and in writing. So bias is inherent in lots of different ways in AI, and it reproduces those biases because AI is uncritical. It cannot stand back and critique. And that means that it creates bias. It reinforces bias. And do you know that? Or do you think it's just there telling you some kind of truth? It makes errors. It's only as good as the sources that it uses. And who will produce new reliable resources if they learned using AI? Errors are inherent in any AI model. The same process leads to errors and to correct summaries. But can learners, can you tell the difference? AI has no judgment, no moral compass. And it's useful now only because it's being used by people like you who did their learning before AI. When it is learned and used by people who have learned only with AI support, we are in serious, serious trouble. How will a de-skilled, AI-trained human detect errors or make judgments of worth in the future? And it will get worse. AI relies without judgment, ethics, or morality on content generated by humans. If AI starts to rely on content generated by AI, as it will, bias and inaccuracy will increase. And as people rely more on AI to do their thinking for them, they will be less and less able to critique what AI produces. And we are starting to see that now. And the result of this will be a power increase for AI, for computing, and a loss of human control in whatever field it happens to be, and a loss of human knowledge, ethics, and judgment. So resist. Beware. Artificial intelligence is artificial. It is not intelligent. It's just a probability or pattern recognition model. But it simulates human language and structured communication and even emotion. But it's a simulation. It's not real. And it depends on what actual humans lodge on the web. And as AI gets a bigger grip, there will be less that humans lodge on the web. And that is dangerous. And there might come a point where we can reasonably ask the question, does AI hail the end of new knowledge? And remember, AI is market-driven. You're up against the AI salesman with their contracts, with their deals of a lifetime, with their trying to make you feel that you're just a little bit old-fashioned if you haven't got the new model. Resist. They're looking for profit. They're looking for position. AI is big, damaging business. It's just business, and there are difficult issues. Do you really want to concentrate knowledge in the hands and control of a few tech billionaires? Knowledge is power. AI is dependent currently and will continue to be so on the exploitation of workers from the global south. For example, in Kenya, where workers are paid $1.50 an hour to act as content moderators, where they have the awful job of looking at the worst content on the internet all day, every day. Do you want to support that continued global inequality and exploitation of people? Do you want to take jobs from humans and give the money to corporations? Doctors are expensive. How attractive to employers or insurers to replace a radiologist with an AI program. Wonderful. Lose your job. And what about social responsibility? Heavy AI use can and will wreck net zero goals. There is a huge environmental impact, which may well be hidden, but is increasingly being shown. AI takes a huge amount of energy, of heat, of cooling, of hardware. Do you want to contribute to the destruction of the planet for the sake of a better email or some lecture notes that aren't even your own thinking? Meta, a huge computer organization, Meta, is about to spend hundreds of billions to build AI data centers. So imagine how much money they're going to make out of this. And just one of the sites that they're going to build is going to cover an area the size of Manhattan. Is that how you want your planet used? And there are at least 10,000 data centers around the world, most of them located at the moment in the US, UK, and Germany, because the global north has got to keep control. And these centers may well consume 1.7 trillion gallons of water globally by 2027. Is that what you want water to be used for? A single AI query, when you just decide you'll ask a large language model a little question, such as a request to ChatGPT, can use as much water as a small bottle you'd buy from the corner shop. So every time you do that, take a bottle of water and pour it away. Is that what you want to happen to the planet's resources? And do you even care? AI is not just another relatively harmless fashion. PBL was not run by 4 tech companies. Social accountability, these are all just harmless fashions. Didn't decimate the environment. Even e-learning didn't destroy professional and academic jobs or deplete students' future skills. AI is a different threat. While concentrating knowledge and power and replacing thinking, it weakens opposition to it and threatens the quality of argument and of learning. So yes, there is a moral panic. While what's really needed is an unchanging foundation in educational planning, focus on student learning processes, focus on the professional skills of teachers, and removal of AI from centre stage. It is just an actor, not the playwright, and you're making it the playwright. It should not be driving your thinking about education. You should start from the learning trajectory of the student. And if there's a place for AI, that will be clear. But there might be no place for AI in learning. What does educational psychology tell us? Well, research shows that expertise that you need to make judgments is created by an organized, memorized, personal knowledge base up here, not out there, by discrete skills of thinking and of performance, by the application and integration of these through repeated use, not repeatedly asking AI to use them. The development of judgment is based on experience and personally created coherent knowledge, not knowledge but created by a machine that is not you. And that is what happens between undergraduate and postgraduate training, and AI cannot replace any of those. And what else do we know? AI cannot teach for the teacher. It cannot learn for the learner. It cannot integrate learning inside the learner's head. And when you're teaching, you're trying to affect what goes on inside the learner's head. Only knowledge and experience enable thinking. And have you forgotten things like active learning? Our job as teachers is to enable students to learn, think, critique, argue, structure knowledge. But when people rely on AI for decision making, their critical thinking drops by nearly 20%. Students who use AI tools for writing struggle with original idea generation. Heavy use of GPS navigation reduces memory and spatial reasoning. I know that from my own experience, but it'll do the same for education and learning medicine. AI-assisted work leads to faster results and shallower understanding, and possibly results that are not as good. When machines start thinking, you stop thinking for yourself. If AI can't teach or learn, where might it fit into the process of education? Only educational design based on curriculum can answer that question. AI is an option like every other teaching and learning method if it fulfills an actual educational need, if it does not do the work of learning. All educational choices must start from your curriculum, and all educational choices must understand learning. There might be no place for AI in your educational process. And I hope you'll reach that conclusion. So my advice is you don't have to become an AI expert. Don't panic about it. Don't use AI just because it's there. Think about what you are doing and the effects of that. Educational design starts from curriculum. Be analytical and critical. Stop focusing on AI. It's just a tool which in learning possibly has no role. Return to proper educational planning. And if you use AI to replace students' need to develop academic, learning and critical skills, you are not preparing them for their future. The real moral panic about AI should be around the cost of losing our autonomy, jobs, and ability to question, reason, remember, and create. So please, stop the moral panic. Hello, and thank you so much for inviting me to speak at your meeting. I wish that I could be there to tell.
We thank ma'am for the thought-provoking session. She'll be joining us online. For
Yes, he is joining online. Yeah. So, can we have questions from participants? The card list.
Hello, Janet. This is Kadambari here. As always, a wonderful talk and something that provokes thought in us as educators. I think you have put, am I audible or is it difficult to hear me? I think she can't hear what I'm saying.
It appears that she is not able to.
Okay. It's okay. It's all right if she. It's okay.
You can come here. Janet, Kadambari is here to pose a question. Oh.
It's not a question.
Hello.
Am I audible now?
The previous one was better for me.
Yeah, the previous one was better. Okay. So what I was trying to say is that as usual, you have provoked thought, and I think we need to look at both sides of the argument, and as you rightly pointed out, let's not get carried away with AI. There are a lot of issues, and I think this is the time when we really need to take a critical look at. So thank you very much for your talk. It was wonderful.
Do we have anybody else? Can you please introduce yourself?
Thank you, ma'am. It was such a lovely talk, and it is an eye-opener actually. And always we have a tendency to get carried away with all whatever new technologies are coming. I am Dr. Soumya. I am the MU coordinator of Mahatma Gandhi Medical College here. And actually I would like to ask you, many a times we blame the tool, but the tool is always not at fault. The responsibility stays with the person who is using. So when we say that AI is the tool, it becomes our responsibility to make it useful and validate it for the proper usage as well. And we should train ourselves first and also our younger generation so that the technology is not misused. Similar thing happened when the computers and other technologies came. Actually speaking, computers when they came, they thought that it will have a negative impact as well. But fortunately so it has not, and we are using it very widely. There are still negative usages, but similarly AI also can pave path to betterment as well. And as educators, I feel it is our responsibility. So I would like to get your opinion on that, ma'am.
Thank you. So I agree with you. Obviously, it's your responsibility to take an intelligent view of this. And you're right in saying that in the past there have been things such as computers which people worried about. And then gradually they reach their own level and become useful. But I think that AI is a completely different thing because it moves the locus of power and control somewhere else. And it takes over fundamental processes of judgment, of thinking, of learning, of creation that we used to try to develop in our students. For me, AI, because it is something which is controlled by tech billionaires, by people who use data for control, who are making a huge amount of money out of this. I think it's dangerous for a number of reasons. It's dangerous because it will reinforce the power of the global north. It will reinforce the wealth of the global north, while at the same time decreasing the autonomy and the thinking ability of people everywhere. It is a different thing. It's not like the other things that suddenly came in. Let's all do PBL. Let's all think about this, that, and the other, which people then run after, and they're harmless because PBL you can reverse, you can give it up, and you should, and all these other things. But AI, you can't. Once you've given away your autonomy, once you have failed to teach your students to do these things themselves, then we have lost the game. And this is politically a really, really dangerous thing.
Okay, ma'am. Actually, even we had the fear when we are seeing our undergraduates themselves, they are starting to use all these chat GPT and all so much. And they don't actually use the right sources, and they are not willing to think on their own. The laziness is there. So this is one of our concerns which you have rightly voiced out. Maybe we have to draw a line.
Yeah, absolutely. I mean, I really think that you should consider that universities need to consider their policies, and actually banning the use of AI would be the best policy. But that is, of course, in this era when we all feel that AI is the future and the sophisticated thing, would be difficult. And also, if you were to stop that, you are saying to people, you actually have to do the work yourself. And who wants to do work? So I think this is really dangerous. But to me, for a university, the most sensible way of approaching this is to look at your plagiarism policies and to be very clear about what is plagiarism. And using AI is plagiarism. And I think that it's plagiarism policies which universities need to look at.
Thank you, ma'am. Thank you so much.
Thank you.
Thank you, Janet. Once again, thank you so much for your critique on AI. I'm sure there were many lessons to learn, and as always, you have been very eloquent. Thank you so much.
Thank you so much, Himanshu. Thank you.
Yeah, we'll be sending your memento to you.
Oh, thank you.
Yes. Okay. Thank you once again.
We request Dr. Ravi Kumar sir, nephrologist, to felicitate our moderator, Dr. Himanshu Pandya sir. Please, sir.
Thank you, sir.
Can I just listen to Dr. Caddenbury's talk, please? Thank you.
For our next session, we welcome Dr. Nair Iqbal sir, MU Coordinator and Professor of General Medicine at PIMS, whose enthusiasm for medical education and structured mentoring style inspire learners across platforms. So we invite you to introduce our speaker and moderate the session on building the evidence-based research priorities in medical education in India. Over to you, sir.
Thank you, dear. Thank you, organizer. I'm privileged to honor one of our teachers at NTTC, BCME, ACME, Dr. Kadambari. So, ma'am is a distinguished professor of surgery at the JIPMER, Puducherry, with advanced qualification including MS General Surgery and Masters in Health Professional Education. She brings dual expertise in clinical practice and medical pedagogy. Her clinical focus lies in breast diseases, and she leads the breast tumor clinic at JIPMER, offering specialized care and contributing to multidisciplinary cancer management. In addition to her surgical role, Dr. Kadambari has made notable contributions to JIPMER Medical Education Department, particularly in the areas of curriculum planning and faculty capacity building. Her scholarly contributions span breast cancer research, pharmacogenomics, and innovation in medical education, with numerous publications in peer-reviewed journals and book chapters. Dr. Kadambari's commitment to both patient care and academic excellence positions her as a respected leader in surgical department and medical education. Thank you, ma'am, for being here.
Thank you very much. First of all, I would like to thank the organizers, Dr. Uday Shankar, Dr. Soundarya, for inviting me to share my thoughts. And a special thanks to my guru, Professor Janet Grant, for agreeing to stay back and listen to what I'm going to say. Much of what I'm speaking is what I have learned from her, and hence she's my guru. So I'm going to move to a more mundane need, moving away from AI, and we've heard a lot about AI during the previous talks. So I'm going to talk a little bit about the R part of MedAIR, that is medical education research, and which is, I believe that there isn't enough being done in this field in our country, and therefore I have given this title of our need to build an evidence base which we can use for ourselves, for our own purpose of improving the quality of medical education that we provide to our students. And I will come to the second part of the title, that is the research priorities, in a bit. So what I will try to answer briefly is, what evidence do we need as educators, and why do we need this evidence? How do we get this, or how do we gather this evidence? And finally, what should be our research priorities. Obviously, when you talk about education or any research for that matter, what counts as evidence is depends on what question you are asking, right? It's pretty logical. So in education, and it probably in all research, you could be looking at what is the impact of an intervention, a particular teaching learning method, a particular assessment tool that you're using. What is the impact on learning, on performance, and so on? Or how does it work? How did this particular intervention work? What is the nature of a problem that you might have? Attendance is a major problem that all of us are facing, right? Lack of engagement. Students are not engaging themselves in class is something that we perceive as teachers. So what is the nature of this problem, going into the depth of understanding? And how is a naturally occurring process taking place, for example, learning, integration, and so on and so forth. Why do we need this evidence? Again, there are many areas that this evidence can be useful for us to inform policy. It's not seen clearly there. To inform practice, our practice as teachers, to improve quality. That is a major concern for all of us. To understand and interpret phenomena, I gave a couple of examples earlier, and to explain why an intervention is not working. So if, for example, we heard just a little while ago Janet speaking about PBL. Now, at the time when PBL was introduced, there was so much talked about. It was so much talked about, and everybody believed that PBL is the answer. That is the way we should move forward. And many universities adopted PBL. But over time, we realized that PBL is not in any way superior to the so-called traditional method of teaching. So to explain, and this came by repeatedly looking at it, looking at reasons where in places where it's not working, why it is not working, and so on. So these are important information that we get from inquiring into issues. So what are the sources of evidence? Obviously, research is a major source of evidence. There is also evaluation. Evaluation is different from research because the question you're asking is different. You're asking if a particular program is working well or not. So you gather evidence using the same methodologies that you would probably use in a research project, but the information, the interpretation of the information and the use of that information is different, and hence I'm distinguishing between research and evaluation. The third very important source of evidence is from our own practice as teachers. Every day we teach students, be it in the classroom, be it in the clinic, be it in the laboratory, and we are observing and we are gathering information in each setting, in each encounter that we have with students. That is a huge source of evidence. So our own practice is a very relevant source of information. Now let's look at this, the information from this. Go back to the previous slide, please. Yeah. So this was a paper published in 2019, which looked at the status of medical research in medical education research in India. There were a few improvements. Number of publications, cited publications, PubMed cited, increased from 2 in 2007 to 31. It's a big jump over 8 years. But if you see the kind of papers, most of them were workshop or program evaluations. They were not actually research. Many of them were surveys asking about whether a particular intervention was useful, not useful, the so-called Kirkpatrick level 1 and 2. So whether it really made a difference, whether they were able to learn something from the workshop and so on. A lot of it, or half of it was by using quantitative methods, Most of it was on undergraduate education. And very few departments like preventive social medicine, physiology, and medical education organizations like FAMER were the major sources of this information. So why is it that our research output, it's pretty dismal. If you look at this, we don't have much going on in terms of medical education research. So why, some of the reasons that we probably could think of as contributing to this lack of adequate emphasis on medical education research is all of us are busy in our, as clinicians, as teachers, we have those commitments which are primary. So we don't have time. We don't have knowledge of methods, adequate knowledge of methods, or even like, you know, the tools that we could use for conducting research. And therefore, there is a lack of rigor. Many of these papers are very simplistic. The conclusions, they use single tools, or they don't have comparative methods and so on, comparative groups and so on. There isn't much support. If you look at funding organizations, there's very little funds allotted, very little. There isn't any funding allotted for education research. But I know for one that it's not just in India, it's all across the world. So, and having a paper in medical education doesn't count for your promotion. That's another peculiarity. So this is again from a recent paper where Dr. Dongre and Dr. Pandya analyzed how much funding is going into what kind of research. And if you see the trajectory of the system, which goes through input, process, effect, outcomes, etc., much of it is on the outcomes. So we look at healthcare, right? Much of the funding goes into healthcare and indicators of the healthcare system, not much into the educational processes. So this is a huge deficit that we face. Therefore, so the same authors have suggested that to improve from overly simplistic studies which have relied on single-site quantitative methods, we need to go in depth and try to explain educational processes in depth. Now, if we needed to do this, given all the constraints that we have, particularly funding opportunities, lack of knowledge and so on, we have to prioritize, right? So the most logical step would be focus on important areas, and that's what I mean by research priorities. So I'll have a question for the teachers here, and maybe future teachers also, the senior residents and others. What would you prioritize if you had to do a, anyway, okay. This slide probably won't work because the Slido is, it's okay, doesn't matter. Can I have a show of hands? Let us say, would you prioritize teaching and learning methods? How many of you would prioritize that? A show of hands? Okay. How many would prioritize assessment? You can't prioritize, I mean, put your hands up for more than one. Okay. How many of you would prioritize curriculum design or curriculum development? Only one. Okay. So, there are several methods by which we can arrive at a consensus of what should be our research priorities, but I'm not going into that. If you look for literature on that, there is plenty. So I will share with you what my priority is, or what I think we should be prioritizing for medical education research in our country. We should understand the educational context. We should focus our research into understanding the situation we are in. And when I use the word educational context, I will give a little background to it, because context is the soil from which education, the processes of education spring up from, right? So nothing happens or nothing worthwhile will be developed unless we have a good understanding of the context. So to give a little more emphasis, which of the two orange circles are bigger? The one on the left, how many think the one on the left is bigger? How many think the one on the right is bigger? Okay. So this is actually both are same, right? So it's how the context around it is what determines the size of the, so this is, this is a borrowed thing, it's called Ebbinghaus illusion. So the social and cultural context of whatever the phenomenon you are studying is crucial for understanding the causal mechanisms. So in an educational, we are all educators, so what does context mean to us? So we can think of macro contextual factors like the socio-cultural factors, the political factors, what our healthcare system is like, and at an organizational and a departmental or institutional, organizational or college level. So studying context is important because, one, it explains differences between interventions, in the implementation of interventions. For example, if we think of OSCE as the ultimate in assessment, then why is it that we are finding it difficult to adopt OSCE here? Is it suitable for our setting? What are our resources? Are we able to have the right kind of setting for conducting an OSCE which will give us valid results? So this, looking into these contextual factors will give us an explanation of why a particular intervention doesn't work. It also gives you an explanation of differences in causal mechanisms, why a particular method works in one context, it doesn't in another. It facilitates success of a quality improvement initiative, so you know the context in which you're implementing that quality improvement initiative, and then you will be able to tweak that to succeed. And it plays a role in shaping cognition or understanding. So this is something which I'm drawing a parallel from Sackett, who is one of the pioneers in propagating evidence-based medicine. He has cautioned that external clinical evidence can, this is in terms of evidence-based medical practice, but you can draw a parallel in education as well. External clinical evidence can inform but can never replace individual clinical expertise, and it is this expertise that decides whether the external evidence applies to the individual patient at all. So if you draw a parallel in education, without understanding our context, without knowing ourselves well, if we adopt something from another context, it will never work. And that is not the right approach. So I am putting forth all these points to support my argument that our priority should be to understand our context. So for any successful implementation, you need to consider all three, not just the content or what you are implementing and the process and how you are implementing, but also where you are implementing it. So this is a very, I would say, seminal chapter from a book, and it's written by Professor Janet Grant, and where she has identified all these factors which influence the development of the medical curriculum. And so all of them are vital to understanding how you design your curriculum, which she has called a contextual curriculum. So all the priorities that you have listed out are also important, But unless we understand all the factors that I have shown you in the previous slide, unless we understand our context well, we cannot find a method which is suitable to us, a curriculum which fits our way of thinking and doing, and that's why I say that we should prioritize that. So to summarize, we need evidence to inform both policy and practice. We need to improve the quality of our research. To address all the challenges that we face, we are short of resources. And I have written a few letters to our ICMR chairperson, but he never replied, and requesting him that a portion of ICMR funding should be given for medical education research. So it's not easy. We are restricted, we have limited funds, and our priorities in the entire system is to focus on the healthcare. So to address these kind of challenges, we need to prioritize our research, and to me, foremost among these priorities is to develop a thorough understanding of the context in which we are placed. Thank you, and I'll be happy to take any questions.
Floor is open for discussion. Anybody wants to like to ask ma'am? I think this research in medical education is a very big topic, and ma'am has just touched the tip of the iceberg. So anybody like to ask anything? Yeah. Dr. Janet, if you want to ask anything from Dr. Kadambari ma'am? Can you hear us?
Yes, I can, actually.
Yeah.
No, I don't think I have. That was a really excellent talk. And the central message that context is important and you need to look at your own context is so clear. But the question of what is context is also something that Dr. Canterbury raised, and whether it's national or local, I think, is also important. It could even be departmental. So I'd like to hear a bit more about what Dr. Canterbury thinks context actually is in this context.
Thank you for that. Yes, so as I, leave it, I'll hold it. So there are the macro context, which is at a national level, the socio-cultural, political, and other things. And then we have the micro context, which is at the level of my organization or my department, what are the factors. But when we are talking about, for example, an undergraduate curriculum, I'm taking curriculum as an example where we look at context, there would be both macro factors and micro factors, which will play a role on determining what would be the, mostly the content of the curriculum, the syllabus, but the macro factors will probably be more important when we design the teaching learning methods and maybe even the assessment, because our school education is uniform across the country. We have a national education policy. So most of the schools follow that. And so I think both would play a role in deciding what would be the most appropriate design of the curriculum. I don't know if I am making sense.
Yeah, absolutely. And obviously there's a point at which research becomes evaluation,
yes,
depending upon the breadth of the area that you are studying.
Yeah.
And both are useful. Yeah. Thank you.
Thank you so much.
Thank you, ma'am. Anybody else want to ask something for ma'am? Yeah.
Not a question, but you had one question, what more research we should be doing. I think that when we want to explain something in educational matters, we often use frameworks and theories developed in Western context. Perhaps I think we need research in India, not to compare methods, which one is better than that, A or B, but we need more research to explain how phenomena of learning happens in Indian context. Of course, we can use Western frameworks to explain those, but we need also some research to check how true they hold when we apply it to our context as well.
Okay, so no more questions, so we can, thank you all. Thank you, ma'am, for your nice talk.
Thank you for that impactful session, ma'am. We humbly request our moderator, Dr. Nair Iqbal, sir, to felicitate our speaker, Dr. D. Kadambari, ma'am. Please, sir. Thank you, ma'am. Now we request Dr. A. Nishanti, ma'am, Professor of Pharmacology, to felicitate our moderator. Please, ma'am.
Thank you, ma'am. Thank you, sir. Our final session will be moderated by Dr. S. Soumya, ma'am, Professor and Head of Pathology and MU Coordinator at MGMCRI, who is admired for her interactive teaching and commitment to innovation in medical education. Ma'am, we warmly welcome you to introduce our speaker and moderate the session, concluding academic session on empowering medical teachers with skills for 21st century. Please, ma'am.
Thank you. Thank you. Good evening, everyone. The final session is by Dr. Jayaprakash Rajan, and he is the convener of the JIPMER Nodal Center. Actually, sir is having quite a lot of publications and so many presentations, and he is a fellow of very reputed organizations, and his areas of interest are educational technology, technopedagogy, academic leadership, and academic auditing. Beyond all this, actually, sir is the person behind training all the medical education unit and curriculum committee members in and around Puducherry, and also many colleges affiliated to JIPMER from Tamil Nadu. And he is the person who has been behind getting JIPMER to attain the status of nodal center, and his continuous and tireless efforts in making the education more innovative within the boundaries given by NMC is very creditable, and welcome you, sir, to share your experience.
Slide open also. So we start or we check the slide? Slide or login. How to log in? How to log in? Login है काम के लिए. Update है. ये करना ले login. Slide open. Okay, leave. No problem. Okay. I'll just do it from here.
So a very good afternoon to everyone. Thank you, Professor Samya, for your nice introduction. And at the outset, I thank the coordinators for giving me this opportunity to share my thoughts with regard to empowering medical teachers in this 21st century. So this topic itself is really close to my heart because we talk a lot of things about education technology, but nobody talks about empowering the teachers, though there are a lot of advancement taking place in medical education and education technology. So people don't talk much about empowering the teachers, whether it is teachers or students or administration or institution, whatever it is, unless you are empowered, you cannot come up with good outcomes. So with this short note, let me move on to the presentation. So the topic given to me is empowering medical teachers with skills for the 21st century teachers. Right. So I would like to quote this. This is the Rappaport's theory of empowerment, which says empowerment is not about giving people power. Many people think that empower means someone will come and give you some power and then you need to act on that. It's not like that. It's about helping people realize what potential already they have, and then make use of that potential. That is the meaning of empowerment given by the empowerment Rappaport theory. Right. Now, this is for your information. This is about the higher education status in India. If you look at the higher education status in India, so we think a lot of advancement have taken place in India. The new education policy and the Ministry of Human Resources and Development report says that 40% of the graduates produced in India are not employable. So unemployability is a big issue in India. So unemployment is a different issue, and unemployment is worse than unemployment. So what is the reason behind this? So the reason behind this are many. I don't have to tell that. The reason are we have a lot of colleges, a lot of higher education institutes, a lot of enrollment taking place, whether it is medical education or engineering education or teacher education or agriculture or arts and science, humanities, a lot of admissions and enrollments are taking place. Are the outputs of these institutions are becoming a relevant input to the industry or relevant into the medical, in our case it is the medical education, medical colleges, or are they directly benefiting the society? It's a big question mark. That's why the report says that 40% of the graduates are unemployable. The reason is, what they cite is that there is no much empowerment for the teachers or for the students. Now coming to the meaning of empowerment, it says, the Rappaport theory meaning says that empowerment in academic setting is the approach and practice that helps learners take charge of their learning for a sustainable future. Underline the word for sustainable future. The empowerment is both process and outcome. When you say process, it is not just people coming and giving you a power. It starts interpersonal. It is both intrapersonal as well as interpersonal. So intrapersonal is that, first of all, I say, for example, if you take in my case, I have to self-introspect myself, understand what powers I have, whether I am using my duties and responsibilities, am I aware of the things going around me. All these things are part of intrapersonal. And interpersonal is, unless I share my thoughts with others, I will not know what are the expectations of the society, or what are the expectations of my student or my fellow faculty are about the society. So that is why it is said the process is both intrapersonal as well as interpersonal. And outcome is achieving the empowerment. So next, an empowered teacher. Who is called as an empowered teacher? Gives students more control, helping them learn independently and with interest. So this will come later on. And coming to the empowered students, who is an empowered student? A student who develops the competence to take charge of their own growth and resolve their problems. So empowerment does not happen automatically. So it needs a lot of time, it needs a lot of awareness, it needs a lot of experience, it needs a lot of interaction between the stakeholders, it needs a lot of interaction with all the elements present in the system. In our case, it is the medical education. Now, since the topic includes the 21st century, let us first try to define what 21st century means to us. So what are the characteristics of the 21st century? So 21st century is marked by digital revolution. I think all of you will agree with this. Wherever you go, we are surrounded by the digital technology, and without digital technology, now all of us are, I can say, we are handicapped without the application of digital technology. And globalization. Globalization has made the higher education more available, accessible, affordable, and acceptable for all. In those days, suppose 2 decades back, if you want to do higher education in foreign institutions, it's a big task. You have to, it's a very cumbersome one, and you have to do a lot of tasks. But nowadays, it's very easy for anyone to do a higher education in, abroad universities or within India. Now, higher education institutes, the foreign universities have set up shops in India, and you can even acquire an Oxford degree or Harvard degree or any university degree in India in the future. It's going to happen. Okay, so that is the beauty of globalization. Anything, whatever you want, you can get in India, in your place, and wherever you want, however you want, you can make. So that is globalization character. That is part of 21st century. And knowledge economy. In those days, knowledge, sharing knowledge, providing knowledge was considered as a service, but no more it is a service, it has become a commodity. Now all institutes have started selling the education, knowledge. So that is why it is no more a service, it is a commodity. So knowledge economy is a big economy. It is, in the 21st century, it is one of the booming economy. So now as we had knowledge, the business processing, process and outsourcing centers, we do have knowledge process outsourcing centers. Wherever you go, this knowledge, lot of academies are there, lot of institutions, a lot of private parties are coming out with new courses and new modules, and that is the third largest booming economy at global level. And lifelong learning. So now you cannot escape from this lifelong learning. In those days, knowledge was little stationary. So college was the only source of education, teachers were the only source of information, but now it is not like that. So in one click, students get information. Students are well informed, but as teachers, we need to upgrade ourselves, whether it is teaching job or engineering job or whatever job it is. Unless you update yourself every day, you cannot survive in the in this 21st century, and otherwise you will get backlogged. And complexity answer, in this 21st century, a lot of complexity are there. In those days, complexity was very less, and there are a lot of uncertainty which we witnessed during the COVID period. And interdisciplinary and integration is again one of the characteristics of the 21st century. No, there is only a minimum boundary between two subjects. In those days, there was lot of difference gap between the subjects. Science subjects, or whether it's arts or science or what. Now almost all subjects have been become interdisciplinary, and the margin between these disciplines are very, very meager. And emphasis on skills over the content. Now, most of the institutes, as I said, that the industries don't look at the knowledge, they look at what skills the students or the output of an education institute possess. So they don't look, there is not much emphasis on knowledge, more emphasis on the skills acquired by the learners. And technological disruption, say for example in medicine, so telemedicine, robotic surgery, artificial, all these things are considered as a disruptive technology. So this technology has brought in a lot of changes in this 21st century, and sustainability and ethics. So knowing something is very easy, but putting it into practice is very difficult. And continuing it and sustaining it is more difficult. So that is again a big challenge in this 21st century, and doing it in a more ethical manner is again a big challenge. And personalization, because wherever you go, everything can be personalized now in 21st century, whether it is air ticket or hotel or your own house or whatever environment you are, whatever you want, including medicine, it can be personalized. Now education is not an exception, even education can be personalized. Personalized system of education is available, discovery learning is available. So that is so these are some of the major characteristics of the 21st century. This, why I'm just letting you know, is that this will give you a background information on why teachers need to be empowered. In the previous slide, I said that there are a lot of challenges in higher education. So one reason is that teachers and students are not empowered. So that is why there is a big gap in education and the transaction of this education to the society. And the 21st century educational landscape. So based on the 21st century characteristics of the 21st century, it has changed the educational landscape also. One is, now earlier it was teacher centered. The teacher decided everything, what to learn, how to learn, when to learn, and what is to be assessed, but now it is flexible learning. So it is student centered approach. Student decides. The student characteristics have changed in the 21st century. They are all tech savvy people, and they want to decide what they want to learn, and they love to do self-directed learning. They no more want a teacher who can stand in front of them and then deliver the content. They want someone who can coach them, they want someone who can walk with them, they want someone who can facilitate their learning, they want someone who can identify best best resource for their learning. So that way, now it has become student-centered approach in this 21st century, and flexible learning. Flexible learning you could have witnessed in the during the COVID learning. So it was flexible learning was facilitated with the help of technology. That time many of the teachers came to know what flexible learning means. And focus on the 21st century. See, industries don't want the current generation students, and they want to upskill them even if they are well qualified also, because the current generation students lack 21st century skills. So how many of you are aware of the 21st century skills? How many of you are aware of the Millennium Document? Sustainable Development Goal Millennium Document, yes. So there are a lot of areas identified as the Millennium Development Goals. One of the important area is the 21st century skills. The skills, soft skills like communication skill, collaboration skill, creativity, critical thinking, research, scholarship, all these things are considered as the 21st century skills. And outcome-based curriculum. So no more discipline-based curriculum is viable, and that is why we have shifted. There is a paradigm shift in the curriculum in almost all higher education sector, which has been emphasized in the new education policy also. So that is called as the outcome-based. We no more test the knowledge of the students, what ability they have, what this particular candidate can, if I recruit this particular candidate, what he or she is able to do for my industry or for the society, for the hospital or like that. So that is the outcome-based curriculum. And competency is no more just assessing the knowledge, it is competency-based assessment, and education has become inclusive and accessible to almost all sectors of people, and emphasis on well-being and lifelong learning. So this is the major change that the 21st century has brought in the education landscape. So this has a major impact on three areas in medical education. One is shift from content delivery to active learning. I think you must be aware of active learning. And competency-based medical education over the traditional curriculum. There are a lot of debates going on about CBME, whether it is the outcomes are achievable or not, whether it is observable or measurable, whether the assessment is on par with the CBME, whether the name alone states CBME, or whether the students are really coming out with the competencies. So that is a continuous debate. There is a continuous debate going on this, and technology of integration of technology and interprofessionalism. These are the major changes happening in medical education. Right. So why do medical teachers need to be empowered? One of the current main crises in medical education is engaging the 21st century learners. So when I say 21st century learners, please recall the characteristics of the current learners. So the main crisis in medical education is engaging the learners. How many of you deny this? Yes, almost all of you would be facing the same challenges, isn't it? So we are the people, we are the teachers who are taught by the last generation students, and now we are teaching the beta generation students, not even the millennial generation. Now the students, starting from the 2025 January onwards, the generation is called as the beta generation. So such a group of population we are teaching who are well aware, well informed about technology, well aware of artificial intelligence, who can carry out self-directed learning. They don't need a formal teacher, and they don't always look forward for a formal education. So that is the first one. And the second thing is advanced learning environment. Now the medical education students look forward for an advanced learning. They no more need four-wall classroom, sit and listen to someone. They want advanced learning environment like simulated environment, real patients, and they want to do something in appropriate settings like community or wards or OT or wherever relevant setting. So they no more want to sit inside the four-wall classroom. Now AR, VR, all these things have come up. So they look forward for such advanced learning environments. And evidence-based, just now Madam Kadambari said that evidence-based priority in research, isn't it? So education is not, and medical education is not an exception for that. So evidence-based education is more look forward. So you cannot just like that go with the content and teach. So you have to look for evidence from different sources. What you read, what is the theory says, what the literature says, and what your personal experience says. Put everything and then come out with the best evidence so that you can transact the appropriate content with appropriate method to your students, provided you follow the appropriate assessment method also. So evidence-based education, accreditation demands outcomes. Now, almost all students, if you ask the students who are looking admission in abroad institution, they will be asking whether this particular university is accredited or not, whether this particular college is accredited or not. Why they look for accredited? Because in accreditation there is an assurance for the quality, there is an assurance for the outcome. So students look for accreditation. This accreditation has created demand for the outcome. So whenever you see the name accreditation, that means there is some sort of assurance. Okay, if I join this college, there is some assurance for the outcome, for my learning. So that's what I said. Education is no more a service; it has become a commodity. Whenever you go and buy a commodity, a product from the market, whatever quality you look, same quality people are looking forward in the education also. That's why accreditation demands outcomes and address challenges. So our teachers need to address all these challenges. It is not an easy task, and shape the future of medical education. As medical educators who are sitting here, you are the custodians of the future medical education, and if you don't involve in shaping the future of medical education, definitely we will be at the losing end. We all will get stagnated unless or otherwise we are empowered. So otherwise we cannot, if you are not empowered, you cannot take forward the medical education ahead. So foster quality and educational sustainability. I said, just now I said about educational sustainability. So it's good to introduce many things, but say for example CBME, it's good. Government has introduced, the apex body has introduced it, but is there any monitoring committee monitoring whether it is achieving the goals or not? Whether everything has been implemented in true spirit? There is no evidence for that. Then the next thing is whether it is sustainable or not. So at present, a particular institute may be performing well. Whether the institute is performing continuously well, it will be a question mark. So it is not a temporary thing. Achievement is not a temporary thing in academic setting. It should be sustainable. If a university gets A grade in NAC, they have to sustain that. So that is why this sustainability is very, very important in education. Otherwise, today you will be achieving quality, tomorrow you will be losing quality. But that should not happen in medical education. Okay. Then next thing is teachers must adapt and thrive. So amidst all these challenges, as a teacher, we need to adapt, because otherwise they will throw you out. So many institutes are looking forward to identify only the lacunae in you, negative points from you. So otherwise they will throw you out. So if you want to survive and thrive in this kind of situation, definitely you need to become an empowered teacher. So these are some of the major domains of empowerment required for a 21st century teacher. The one is the pedagogical and the assessment skill. So how many of you are confident that I have a good pedagogical knowledge and I have a good knowledge and skill of framing good assessment for my students? Is everyone confident? Yes, including all. It's because we cannot confidently say yes, because there is no much awareness about the pedagogy. So all these days, whatever we are doing is that we go with the content and think that that is the content and deliver that in the classroom and think that we have delivered. So that is not actually. So as I said, as in the previous session it was said that everything should be evidence-based, identifying the content, delivering the content, assessing the outcome, everything need to be evidence-based. And digital and technological skills, as teachers, we need to equip ourselves with the current technology and emotions. One of the most neglected area is socio-emotional learning in medical education. We talk a lot of science in medical education, but we totally neglect the socio-emotional part. So this part, again, we need to equip ourselves, then you can call yourself that you are an empowered teacher. And the next domain is the leadership and professionalism. So a lot of things are coming up and people don't take responsibility for their learn. The day you take responsibility for whatever you do, then you are called as a leader. The day you realize what are your real duties and responsibilities, you can be called as a leader and you are a professional. So that is again one more 21st century skill. So pedagogical and assessment skills, use adult learning principles. Suppose if you want to equip yourself as a skilled teacher with regard to the pedagogical and assessment skills, you need to use adult learning principles, then active learning methods, see that your classrooms are interactive so that you can interact, engage students in a more productive manner, and authentic assessment. So what do you mean by authentic assessment? Assessment in real settings. So before authentic assessment, your learning should be made meaningful. So you need to identify teachable moments in a classroom. You cannot just like deliver a class, deliver a content using a PowerPoint. See, you need to understand who are your learners, what do they want to learn, whether they are learning or not. Are you delivering the, a meaningful learning, whether meaningful learning takes place in the classroom or not, and are they being assessed authentically or not. So that is part of pedagogical and assessment skill. And your duty is, suppose as most of the time we play the role of the examiner, but we don't play the role of feedback provider. So again, that is one area where our teachers need to equip themselves and generate higher level of evidence of learning. All these days we are generating evidence. What evidence you have for your classroom activity? How many of you maintain a teaching portfolio in your, how many of you maintain a teaching portfolio? How many of, yes sir, very good. So there is one person who is maintaining. So what is the use of this teaching portfolio? So it helps you to self-introspect what you teach, what you have taught and how you are taught, what is the feedback and what improvement you made. So all this teaching portfolio will help you to understand the path you are traveling, the path you have traveled and where you need to reach. So teaching portfolio is one example for this thing, generating higher level of evidence. So all of us, as I said, that one and the only evidence all educational institutions have is the marks of the students. There are lot of hidden evidence available which we teachers most of the time neglect. Starting from the attendance and the day they get the graduation, there are lot of evidence you can generate, the institution can generate, but most of the time we neglect those evidences. So if you look for these evidences, then you can call yourself as a teacher, empowered teacher. Then the technological skills, the current teachers should equip themselves. One is they should be able to use the learning management systems and digital tools and create interactive educational content. So no more we don't have to use the others' content. You are expected to create content on your own. So we are expected to be creators, but we expect our students to, unless teachers become creators, you cannot make your students to think creatively and they will not become a creator. That's what the industry or the society needs. We want creators. So if you want your students to be a creator, you need to be a creator in your environment, in your profession, and use simulation, augmented reality, virtual reality and mobile learning in your day-to-day teaching, and use artificial intelligence as a learning partner, resourceful learning partner. So many of you critique artificial, but it is a good learning partner. If you use it, judiciously and more rationally, definitely it is going to be a good learning partner for you. It will help you in making questions. It will help you in creating content, help you in creating session plan. It will help you to what? Even compare what you have prepared and what it has prepared. So there are a lot of advantages. So that's why I am calling artificial intelligence as a learning partner for you. If you realize that, you can become an empowered teacher. Then emotional and social intelligence, this already have discussed. One is you need to be a supportive teacher, creating a supportive learning environment in your classroom. Then you can call yourself as a empowered teacher. Handle diversity and inclusion. Now the current generation, as I said, since education has been globalized, you can expect tomorrow someone from South Africa or from African country or other Asian countries, from America, US, because education is very affordable in India. So you can expect some foreign students sitting in your classroom. And now it is always wherever you go to in India, now because of this need, each and every classroom is like a mini India. If you come to JIPMER is always like a mini India. You can come across students from different states. So in that case, you need to develop your cultural competence also. You just being a knowledge provider will not help you. You need to understand the cultural competence. You need to develop the cultural competence so that you understand the cultural the culture behind each and every student. So accordingly, you can tweak your teaching sessions and then engage the learners effectively. And handle diversity and inclusion and practice empathy and resilience. So these are some of the things. And about leadership and professionalism. So already the NMC has included this as one among the 7 roles. So leadership and professionalism. So I don't want to discuss much about this. And empowerment strategy. There are 3 empowerment strategies where a teacher or an institution or student can be empowered. One is at individual level. When you say individual level, it is both individual and the pure empowerment. One is first know your learners. Know your learners is just knowing your customer like that. Who are your learners? What are they? What do they know? What they want to learn? And what are their interests? How much they spend in time spent in library or digital, mobile phone or like that. So first of all, know your learners and undergo training and faculty development programs and participate in conferences like this. Networking will always help you to upgrade yourself and always embrace co-teaching. If your session is more than half an hour, please opt for co-teaching and encourage peer observation. ask your peers or seniors or juniors to come and observe your sessions and then ask them to give feedback and initiate new. Don't hesitate to initiate new things, because as I told you, this knowing is very easy, but putting into practice what you have learned is very difficult. If you start putting into practice what you learn, definitely will make you an empowered teacher. And collaborate with others, take feedback, start mentoring. So mentoring can be done for your juniors, subordinates, as well as for your students also. Accept responsibility. That starts your leadership. And reflect after teaching. Teaching portfolio, this already I have discussed. And please do educational research. Conduct educational research, start at small level and then progress at the higher level, and learn a new tool at regular. So make it a point that every 3 months or every once in 6 months or once in 4 months or 2 months, I will learn a new tool and then use it for my teaching learning routines. So then institutional empowerment. So institutions should encourage people. So because it's top to bottom approach. If institutions are not aware of empowering their students and teachers, so institutions cannot become empowered institutions. So institutions should encourage teachers to attend FDPs, conferences, networking, all those things, and recognition. So institutes should acknowledge and recognize the teachers' work. So they can even institute some awards or acknowledge them. So there should be some sort of reward for the teachers so that they get recognized, and freedom to innovate. So always feel free to innovate things. Don't hesitate to experiment things in education so that you can become an empowered teacher. So empowerment is promoted in work environment that provide employees with access to information, resources, support, and opportunities to learn and develop. So who is an empowered teacher? Now, after listening to all these things, who is an empowered teacher? Who is socially motivated, technologically sound, and professionally equipped teachers. When you say socially motivated, unless you are socially motivated, you will not be able to interact, you will not be able to create an interactive atmosphere in your teaching learning thing. And you need to be technologically sound, should be able to identify appropriate technology. And third thing is, you should be professionally equipped. Then you can call yourself as an empowered teacher. Then engage learners productively, predominantly 5 C's. These 5 C's are nothing but communication, collaboration, creativity, critical thinking, and connectedness, that is networking. So if you are capable of doing all these 5 C's, then you can call yourself as an empowered teacher. Always start with engage your learners at the lower order and then take them to the higher order. This can be possible only if you start using high impact teaching skills. So when you say high impact teaching, it's not just ordinary lecture or PowerPoint. It can be even before starting a lecture, during the lecture, and after your session also. So learning is a continuous process, and your assessment should also be continuous. Then your teaching becomes an high impact teaching, and you can call yourself that you are an empowered teacher with possessing high impact teaching skills. Then the next thing is capable of designing educational encounters and take educational. Just now, Madam Kadambari discussed about how to make an educational, how to identify a research area for educational intervention. So identifying is very easy. So assessing the outcome is more important. So intervention is easy, but assessing the outcome is very important. And handle socio-cultural gap and digital divide is again a component of empowered teacher. So this guide will help you. This is adopted from Harden. This will help you to choose area for your empowerment. Just look at this. This is a popular slide, picture taken from Harden and Crosby, which says the 12 roles of a teacher. Suppose now you can check. So which are your areas where you are strong enough, what are your weakness, and where are the opportunities lies, and where you can what are the challenges you face in this thing. So that this will help you to identify the area for empowering yourself. Then the next slide is for using the technology appropriately. This will help you to understand how good you are, how good you are in using, selecting and using technology in your day-to-day. This particular framework is called as the TPAC. So it talks about techno-pedagogy. So one is, you should be a teacher not only familiar with the technological knowledge, not only familiar with the pedagogical knowledge, not only familiar with the content knowledge, you should be able to blend all these things appropriately and transact the content in your classroom. Whether it is a classroom, online or offline or whatever it is, so you should be able to. So this framework will help you to transact the content using technology appropriately. So these are some of the guiding. Some of you may ask me, so I say all these days I have been doing a lot of things. Only thing is that I don't document things. I don't an area to start. But these guiding questions will help you to understand where you can start developing your teacher empowerment so that your students get empowered. Unless you are an empowered teacher, you cannot create a student community who are empowered, and your institute will become empowered. So, as if you are a teacher, empowered teacher, you can create empowered student, and that will create an empowered institution. Definitely, such institutions will definitely create an empowered nation like India. So, these are some of the guiding questions which I am leaving it for you to read. So are our students assessed fairly to meet the curricular objectives? This is one important thing which you need to ponder over. And are the attitudes of our students taken care and nurtured? Like that, the next question. And what kind of remedial and enrichment opportunities are available? So these are all opportunities for you to self-introspect yourself and know whether you are an empowered teacher or not. And finally, how far is the education system accountable for our students' learning? When whenever people hear the word accountable, they think that it's a very scary term. So accountable is not a scary term. So determine yourself that from today onwards, I will be accountable for my teaching. I will be accountable for whatever that happens in my classroom or institute. That means you will start documenting all your activities. That starts your accountability. So as a teacher, what makes you feel empowered? So I just one day before I thought, how can I make this session more interactive? I introduced some Slido into this, but it is not working here. So the next thing what I tried is, I thought I will conduct a survey among the NTTC participants, BCME, ACME participants, and some of our JIPMER faculty. So I got these real stories. One of the faculty said, these are some of the moments they felt that they are empowered. So the moment one day that particular teacher used digital tool and made his or her session more interactive, so that made them to feel empowered. The second faculty said, he introduced OSCE in his department, and that made him to feel empowered, and opted for associate. One of the faculty member, when given an opportunity, he grabbed the opportunity to become associate. That now he feels that he is more empowered. He is able to use whatever he learned in medical education. He is able to execute those things, and underwent training. In one of the faculty said, after undergoing a qualitative research, he felt that he is more empowered in doing educational research. And one more faculty said, faculty of being a faculty in MEU, empowered, increased the empowered, acquired empowerment, and feedback from peers and students also gained empowerment. And here is, so I just requested last night some of our distinguished personalities and who are our NTTC alumni to share their moment when they felt they are more empowered. So he is, I think Dr. Professor K.R. Sethuraman needs no introduction. He said,
because the intense turmoil we faced in adapting to the COVID pandemic disruptions 5 years ago, I was the medical dean at AIMS University in Malaysia then. Thanks to the 20 years of experience at the National Teacher Training Center at JIPMER, I could empower and enable 100+ academic staff to smoothly change over to online teaching and assessment. I had mainly used 3 principles: Miller's pyramid of competence, Dale's cone of experience, and hybrid simulation techniques for competency training and holistic assessment. In 2021, December, Professor Raymond, the national assessor, declared that AIMS model of improvisation during pandemic was the best in Malaysia. So we felt really happy, and I believe true empowerment is when we can inspire others in a crisis. Thank you.
So he feels that inspiring others is the true empowerment. So the message is that please work locally to inspire globally. We always talk about, even now also Professor Dr. Amul was discussing about the frameworks, Western. We are more fond of using Western frameworks. So let that be there. So we need to perform locally to inspire globally. So for that you need to test lot of these things and then experiment with education. And the next person is Dr. Ram Narayan. He is also a popular person. He is currently
as a teacher and educator.
Academy.
I was
empowered initially when I attended the NTTC teacher training program in Jipper, Puducherry. That was when I realized the power a teacher has, the influence a teacher has, the inspiration a teacher can have on the students. And it is also a turning point in my life because that was the time when I first came to realize how much an empowered teacher can influence the students. And I must look back with gratitude at the teachers who really made me believe that I can enjoy teaching, contribute meaningfully to this role as a teacher. This is something which I have enjoyed, and over the years, every time I have taken a class, every time I have conducted a faculty development program, I have relished the moment when at the end of it, I felt the participants or my students have understood me. I have made them understand things better. I have facilitated their learning. So really, if you ask me what really empowered me, it was the continuous belief in that I can be a teacher, can make a difference in the lives of those who are coming into contact with me.
So actually, their commitment to medical education is very visible. Their empowerment is visible. So last night I just sent a WhatsApp message to some of these people, and these two distinguished faculty, they immediately responded with by sending a 1-minute video. That shows their commitment and passion towards medical education. I'm really thankful to those.
Hello, I'm Dr. Senthil.
Any questions?
Thank you, sir. You have brought out the nuances of the teacher getting empowered to empower the students. It was really very informative. And another is, we are now at the crossroads. The 21st century, everything is available at the fingertips. Truly in the fingertips. Anywhere you touch the screen, you get the information. So overload is there. At the same time, as Dr. Janet raised the concern, there is also de-skilling, which you have also brought out by saying that there is unemployability for many of the students. So that empowerment can overcome these challenges. So thank you so much. Any questions from the audience?
Sir, can you highlight some of the competency frameworks which addresses the upgradation, or what do you say, the empowerment? They are getting revised. For example, CanMeds 2025 has an upgradation in competency. There are no more 7 roles, it's more than 7 roles. Could you highlight on those?
There are a lot of, as you mentioned, CanMeds framework is there, the UK's tomorrow's doctor framework is there, Dundee's model is there, WFMA has come out with now a new model, and NMC has revised these 5 roles to 7 roles. So recently, so last year only, when they introduced it was only 5 roles, now they have increased the roles as 7 roles. So there is no, I don't believe in competency. Competencies are only guiding this thing, what do you say, guiding thing. But there are still many things which are hidden. We call it as the hidden this thing. So these competencies help us to make our educational outcomes more visible. That is where we can use the competencies and for assessing the, the major outcomes of an individual. So otherwise, competencies are subject to modification depending on the current. So I said, so if you look at the 20th century, the competencies are different, the expectations are different. But now the expectations are different, so people, the agencies, the apex bodies or the so-called agencies are keep changing the competency framework.
Sir, in the same line, in the name of improvement and development, don't you think teachers and learners are overburdened?
Here, this is a nice question. So if you think it is overburdened, so that is where I said that engaging the current learners is a big challenge. As teachers, you need to think more smartly. Don't think it is a overburdened. Because I used to tell my participants, whether it is NTTC or ACME or BCME, they used to always complain that the NMC has increased these things. I used to say that earlier you have 50 students, you had 50 brains to work for you. Now you have 100 students, you have 100 brains to work. Now the NMC will increase 200 seats. Don't think that it is a burden for you. Take it as an opportunity, because it's a challenge. You have to convert this challenge into an opportunity. Think that there are 100 brains, 200 brains to work for you. Don't think that you only have to master the class. Don't think you are a sage on this stage and you wanted to dominate the class. If you think that you want to dominate the class, definitely it is going to be a burden. If you think that students are also part of your educational resource, definitely it is going to be a pleasurable, enjoyable experience. So think there are 200 brains for you to work. You don't have to go prepared to the class. Just delegate the work to your students. Take a content. Ask one student to prepare a PowerPoint. Ask one student to prepare a lesson. Ask one student to prepare MCQ. They will come out with beautiful lesson plans better than we teachers. I have witnessed this. I have spoken to students. We have done this experience. Dr. Zakaria Bobby conducted an educational experiment in our JIPMER. He made students to create MCQs. You won't believe that some of the students created better MCQs than the teachers who are experienced. He has published that paper. He has published it in BOMPMED, Biochemistry, Medical Education and Research, PubMed Index thing. So what I mean to say is that students are also a resource, or I can say they are the neglected resource in medical education. But if you look at other fields, they are leveraging on the student resource. If you look at AICT, engineering education, IIT, IIM, they always students will be on their toes. But only in medical education we have this complaint, honestly speaking.
JP, good presentation. I have one question pertaining to self-regulated learning, because that's also one of the important skills that is required by the 21st century. So with respect to the students, we should, I think, probably promote the self-regulated learning, and at the same time, as faculty, as you say, sit back, relax and enjoy, because there are 100 brains at working. What is your thought on that?
Good. Now it is the age of self-directed learning, and as I said, students no more need a formal education or a formal teacher. They only want a coach, a teacher who can walk with them, who can understand their philosophy, and who can, support team teaching, who can support, small group teaching kind of thing, interactive teaching. That kind of teachers they are looking for. They don't want, slowly the concept of formal teaching is coming down. That is why, I don't want to name some institutions where attendance is not given importance. Earlier we believed that attendance forms the basis for attitude development. That is why we insist students to come to classroom from this time to this time. So that we thought that will instill values like punctuality, regularity and attitude. But now that is no more, because anytime, anywhere they can have access. But still it is a question mark, but we need to revisit all these philosophies we believe in. So similarly, what you said is that self-directed learning, most of the students want to be, do self-learning. For that, we teachers need to be more well-equipped so that we can give them proper directions. So earlier it was directed self-learning, now it is self-directed learning, and slowly it is going to become self-determined learning. So we have to start with the directed self-learning. For that, we teachers need to be empowered. Then self-directed learning. But we are directly starting with self-directed learning. Yes, sir.
I'm Dr. Henry Baldach, Professor and Head of Physiology from Sri Manakula, Sri Lakshminarayana Institute of Medical Sciences. I want to add a small adage. The teacher should expect the student to do one better than him. That's all.
Any comments on that? Okay. Good, sir. Thank you.
Excuse me.
Yes?
I have one more view on medical education research. Why AI become popular? Because all teachers are mandated to do research. This is why this is getting popular. So, as time progress, we don't get real research. No one to read the research. We'll get only the products. Okay. So, this is all because of, I think, overloaded assignment to teachers even. I mean, it is mandated by NMC, whatever. So we are not really enjoying the work unless we wholeheartedly involve. That was the real research happened before. Okay, we should revisit these things. So, of course, thank you.
Good, I agree with you. So definitely STC, it all depends on the philosophy you believe in. If you are a strong believer of, so people who do research, there are some people who strongly believe in the principles of research. There are some people who just like that experiment. There are some people just casually do research, action research inside a classroom. I am a person who strongly believe in action research. So in this classroom now I am just scanning and then doing an action research. How many are listening to this actively? More than hearing is listening. So there is a small action research. This will help me to fine tune my this. I don't have to go and publish and then this thing. This is for my self-improvement. If you want to do research just for publication, definitely whatever you, Dr. Mohammed, whatever you said is correct. I accept that. If you want to do research as a passion to understand the process, understand the phenomena, you don't have to bother about the publication. So that is my personal thing. So I believe in a philosophy where I can do research to get an immediate solution for an immediate problem. Educational setups need to identify immediate problems so that you can identify a tentative solution and apply that in your classroom setting, see whether it is working or not. That need not work for your setting. So I want to check whether it is working for my setting. And if possible, I will let the outer world know that one. So for that, suppose if I want to make it, generalize it or something like that, whatever you believe in, then I can go for a big large scale research and then publish it. So here is where the system has made a mistake. Since they said that it should be published, so everyone went behind that and then lot of predatory journals came up. So people who have a real passion towards research, they lost their interest also. Okay, suppose, don't worry about if you are really interested in doing educational research, start doing small action research in your classroom. Check how many students are giving feedback, why they are giving feedback, why the rest of the students are not giving feedback. Why the same student is asking question, why the other students are not asking question. So ask this question to yourself. I said that how many of you are using a teaching portfolio? Your own teaching portfolio will give you insights on educational research. Why at this particular context I performed a good teaching, why I could not perform well for a particular content, why with this group of students I did well and the other group of students I could not. All this self-introspection itself will give you a good insight. You don't have to do a big research. Ask those people who are doing research. I don't want to comment or discourage people who are doing education research. They are just doing research, just comparing this method and that method. What is the use? How can you compare carrot and tomato? Carrot is always carrot and tomato is tomato. Everyone, all methods, all techniques have its own advantages and disadvantages. Even the best method you say there will be some, because you are handling human beings. Human beings are, there are a lot of individual differences among human beings. And that too, formative stage students are totally, there are a lot of variations in their individual difference. So that way educational research should be a passion for an individual. Just for the sake of the system says I have to do education research, if you do that one, as Dr. Mohammed said, you will end up in that one only, you will lose interest. So that is a small message. That's my personal opinion. Okay. Thank you very much. Thank you for your patient listening.
Thank you very much, sir, for the insightful words. And with this session, we are coming to the conclusion of this MedAIR conference. Thank you all for participating and thank you the organizers.
Thank you for the uplifting session, sir. We humbly request our moderator, Dr. S. Soumya ma'am, to felicitate our guest speaker, Dr. Jayaprakash Rajan, sir. Please, ma'am. Thank you, sir. We now request Dr. Manoharan, sir, Professor from the Department of General Surgery, to felicitate our moderator, Dr. S. Soumya ma'am. Please, sir.
Thank you, ma'am. Thank you, sir. You will receive a feedback form through WhatsApp. Kindly fill that form. You will receive your certificates after 2 days.
We now proceed to the valedictory session, marking the successful conclusion of MedAIR 2025. We would like to first felicitate our tireless and dedicated organizing secretary, Dr. R. Uday Shankar, sir. We kindly request our Honorable Director, Dr. R. N. Kagne, sir, and Dr. K. Soundarya, ma'am, Deputy Dean Academic, to felicitate our organizing secretary. Please, sir. Please, ma'am. Thank you, sir. Thank you, ma'am. Now we come to the prize distribution ceremony. So first we'll be awarding the oral presentation winners. So it was divided into two groups. From the first group, the first prize goes to Dr. Hari Krishnan Ilangovan. And second prize goes to Dr. Murugesan Vimal, sir.
Next we have from group 2. First place goes to Dr. K. Ashwati Ravindran, ma'am. Second place goes to Dr. Niveta S. Next category is original article based poster for faculty. First place goes to Dr. S. Satyamanasa Gayatri Vinay, ma'am. Second place goes to Dr. Vijay Shankar Palaniappan, sir.
Next, we move on to the concept posters by faculties. So again, it was divided into two groups. From the first group, first prize goes to Dr. Megha Snigdha, ma'am. And second prize goes to Dr. Usha Dhanaraja, ma'am. Second prize goes to Dr. Usha Dhanaraja, ma'am. From the second group, first prize goes to Dr. R. Logamurthy, sir.
Let me tell you all the story about a mouse named Lori. Lori was a mouse in a big brown house.
And second prize goes to Dr. Sunil Subramaniam, sir. Next, we move on to concept poster by postgraduates. First prize goes to Dr. S. Yuvalakshmi. And second prize to Dr. S. Sriram. Finally, we have the QR challenge winners, Dr. Usha Dhanaraja ma'am, who finished it first within 28 seconds and has scored 10 out of 10. And second prize to Dr. Y.C. Nalini ma'am, who's also got 10 out of 10 in 39 seconds. Thank you, dignitaries. On behalf of the organizing committee, we thank all the esteemed speakers, dignitaries, moderators, delegates, and participants for making this event a grand success. High tea will be served at the back of the auditorium. Thank you. Have a pleasant evening. We request everyone to rise up for the national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंगा विंध्य हिमाचल यमुना गंगा उत्कल जलधि तरंगा तव शुभ नाम है जाहे तव शुभ आशीष माहे ताहे तव से दाता जनहन मंगल नायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे